Good morning, thank you, and welcome to our Mountain West Inspiring Quality Forum. As many of you are aware, since you did sign up to be here, we are here today to talk about quality, safety issues in surgery, and how we do this a little bit better and how we're doing things right now. Thank you all for taking time out of your schedules to be here. I know that we are all extremely busy, and your presence recognizes that this is something that's phenomenally important for us to be pursuing, both at the individual and at the collaborative level in our surgical practices. We have a terrific team here today to share knowledge, wisdom, and experience with you, representing everything from a rural practice in Gillette, Wyoming, to our CEO up at the University of Utah. So we've got a very diverse background panel and speakers to bring to you as part of what we're doing. Quality is something that's becoming an increasing issue and is something that's being more recognized not just by us in the healthcare field but also by our patients. They're starting to get an understanding that quality, value, and patient safety are very important parts of having healthcare delivered to them. And as this becomes more of a public issue, we're also seeing it trickle over into the policy arena, where we are looking at payment models that are more based on the quality and value of care that we deliver rather than simply being based on fee for service. Because of the importance of that, the college started putting together these inspiring quality forums. Dr. Hoyt shared with me this morning that this is the 17th IQ forum that has been hosted across the United States, and we are very proud that we've had the opportunity to do this. With that, I actually am going to turn things over to Dr. David Hoyt. For those of you who do not know him, he is the Executive Director of the American College of Surgeons, and that's a tremendous job with a lot of responsibilities that go with it. I, of course, recognize Dr. Hoyt's name as someone who came out of the trauma tradition and someone who I looked up to as a mentor in the trauma and critical care field. And he is going to share some thoughts and some background with all of you in terms of the IQ forums, what we're doing, and how we can take this forward.
Well, good morning, and thanks, Amelia. This is really a privilege for us to be here as part of your quality forum. And we started these to really try and help create a conversation in the community about quality. And I think after doing this for a couple of years, we're really pleased with what we're seeing. What I'm going to do is try and give you a little bit of the background where I think we are in quality, and then we'll get into the details with regard to the Salt Lake area. My slides, please. Okay. We just finished the celebration of the 100th year of the college, and you can see from this picture here Dr. Martin operating without gloves and no mask, and then a modern operating room. So we've really come a long way, and it really has been a tradition of quality. It was started really by this comment with a discussion before the Board of Regents in 1917 or 1916, and the program then started in 1917. And Dr. Martin said, we are face to face with grave problems. First, the discrepancies in the standards of efficiency. By that he meant the quality of care and just the overall resources available in a hospital amongst hospitals in which recognized leaders in surgery do their work. So he was calling the question on behalf of the leaders in surgery to do something. And it's really from that this hospital standards program started, which ultimately became the Joint Commission. The Joint Commission rolled out of the college in the 50s. His collaborator in this was Dr. Ernst Codman. We just celebrated his contributions through a ceremony at the gravesite in Boston where he was buried. He died a pauper. He did not want his wife burdened with having to pay for his gravestone, so he has had no gravestone. So the college organized a number of people to put together a little fund and created this gravestone, and then we dedicated it this July. You see Dr. Codman there with the first registry. This is a sarcoma registry. He was interested in in bone sarcoma. He was interested in shoulder surgery. He was a very broadly involved surgeon in much of orthopedics as well as general surgery. But there he is with the first registry. So our tradition that spans over 100 years started again with this hospital standards program in 1917. The Commission on Cancer, which is an organization of 50 organizations that the college convenes, led to cancer standards in the 20s. The Committee on Trauma followed through. The Joint Commission spun out in the 50s. And in the last 5 to 10 years, under the leadership of Tom Russell, Katie's here today, her father really helped bring the NSQIP program in to the college. And we now have many other programs, including bariatric surgery, TQIP, et cetera. So really, if you think of one thing in addition to education that defines the college, it's been our commitment not just to quality per se, but to developing the tools and structures to support this effort. And from this, we've really developed 4 principles. The first principle is to set standards. So think of a trauma center or a cancer center or a bariatric center. You go through an iterative process that's evidence-based when possible or consensus-based when not, to create a set of standards for how care should be delivered. The second step is then to actually build out the infrastructure, the so-called process of traditional quality improvement. So that has to do with the staffing levels, specialist mix, checklists, et cetera, all of the actual specific elements you use to build that program. The third step is from the beginning to commit to measurement, the development of data to measure performance against those standards. And then the fourth commitment is really to external verification. Now, if you think about it, when a patient tries to choose where to get their care, this is really our commitment to patients to show them that we're actually doing what we say we're doing. So external peer review and verification is a very important step as well. These 4 steps have become the college's model for quality improvement, and I think there are many that are following the leadership the college has put forth. Now, when the ACA came forward, the Board of Regents and the Board of Governors had a conversation and said that as we judged our participation in that, it should really be against some principles. And those principles are listed here. It needed to be about the patient, patient-centered, physician-led, quality-driven, and efficiency-based. And I think that's been very helpful for us as something has come forward, particularly in the regulatory phase, to use this set of principles to judge how we're going to react. Now, there is, for the first time, really increasing alignment. If you look at the ACA from a distance, and arguably there are a lot of things to be concerned about, but from a distance, there are really 3 principles that were put forth in this law. The first is access to care through insurance reform. And you can argue about the false starts that have occurred in the last 18 months, but the bottom line is there are 9 million more people insured than there were 18 months ago. And in fact, you're starting to see this reflected in state budgets, actually announcing lowering of costs due to the available funds that this has created. The last 2 goals of this law, though, were really payment reform and delivery system redesign. And those are connected, perhaps in more subtle a way than we sometimes think. But the payment reform initiative was aimed at really lowering costs. We all would agree that that's important. And we'll have to wait and see what works. But things such as bundling of care and charges, accountable care organizations, bundles of bundles, if you will, those kinds of models are really intended to create payment reform and lower costs. And delivery system redesign was really intended to be through performance measurement. And I'll show you then how the government, at least, and the payers have put together an infrastructure that's going to be with us for a while, so it's important that we understand it so we can participate. In many ways, this is based on the principles of Porter and Teesberg, who wrote the book Redefining Health Care about 15 years ago. And what they simply said in this book was that if you measure and publish quality reports and measure and publish price, then the marketplace will help to adjust and select best care and lower costs or true value. And I think that's really what we're in the middle of, and that's really what the intent of this law was in its most positive way to look at it. Now, there is, again, alignment at the federal level for the first time as well. The U.S. Department of Health and Human Services under Kathleen Sebelius put forth the National Strategy for Quality Improvement, and I'll show you what that means. But the emphasis there was better care, healthy communities and people, and affordable care. So those three principles are really behind that quality improvement strategy. The triple aim, which is the philosophy that was put forth in CMS under Don Berwick's leadership, is aligned with that. So improving the experience of care, improving the health of populations, and reducing per capita costs. And then finally, the learning healthcare system. So the concept that the Institute of Medicine has been working on for the last 10 years of really putting evidence in context and using it as a basis for quality care. Now, a lot of this is really about payment reform, and what we're seeing is a slow progression or movement from so-called volume-based payment to value-based payment. And the reflection of that is really going from payment for service to payment for a population. Although we're not there yet, we're somewhere in the middle. And again, as this evolves, how quality is then matched with that is really, I think, our opportunity to influence what we're going to subsequently live under. Now, this incredibly complicated looking slide is really the structure that's been put in place. And I want to take you through this briefly because I think it's important that every physician and provider understand at least conceptually what is evolving. And at the top, you see there's an attempt to define high-value care. Secondly, there's a system for performance measurement that's being developed, and I'll show you how that's going about. And then finally, performance improvement. And performance improvement is being driven really by payment reform and incentivization using quality measurement as the basis. And this structure is what we're still in the middle of setting up, but it's really what is coming, and it's our opportunity to reshape it and participate in it if we choose to do so. Now, at the top is this national framework for high-valued care. And we don't have time to go into the details of it, but suffice it to say that the National Priorities Partnership initially established what the focus of high-value care would be. That is now managed through the National Quality Forum. And again, there's a very detailed process that puts forth measures. The whole field of measurement science is evolving from this, and how you pick measures to prioritize your high-value targets is really what this is all about. So that's the initial stage. Decide what the priorities are and pick measures that reflect those priorities. The second is to find data then to support this so that you can measure performance. And what's going on, you can see at the bottom of the slide, selection of healthcare priorities. So that was the first slide. That's the first step. And as you do that, then you develop measures, and then you start to look for ways in which that data can be collected. And health plan data, office data, hospital data, clinical laboratory data, electronic health record data, and registries. Registries is a tremendous opportunity for us as a college and as a profession to participate in this. And all of that data is slowly being put together in a platform, and there's software now that's being developed that can aggregate that data. You may have heard of the concept of so-called big data. What that really means is that software is used to take these variety of sources of data and aggregate it through a process of extracting the data, transforming it, and then loading it into these platforms. And then business intelligence software is on top of that, actually creating reports. Now that sounds like a huge sort of IT undertaking, and I think it is, but this is the overall strategy where we're going, so that the ability to put cost data together with quality data is real, and it's coming, and I'll show you an example of that already, how that's occurred. So the final step then, once you've set the priorities and come up with a data source to be able to measure performance, is to then link that to actual improvement. And the mechanism that's being used is an incentive-based payment scheme. And this just shows you conceptually how this works. So you have a family of measures for some problems, such as diabetes or patient safety. You've come up with 16 or 17 different ways to measure that. You then take elements of that and put it together into a package against which the clinician is measured, or a hospital is measured, or any other provider. And then through that, you create an incentive or payment system that brings about the behavior you're trying to incentivize. And that is the schema by which quality is going to be managed, at least in the foreseeable future. Now, as we've gone around the country and listened to people in the quality forums, we have learned some principles that are really very common, and they're listed here. The quality improvement really is the future of medicine, and I would argue that that's going to emphasize not just quality but value. Quality is measurable. There's a general consensus that that's in fact true. High quality data is essential for quality improvement. Quality thrives in a supportive culture. That's an incredibly important concept, and we'll emphasize that a little bit later. It's incumbent upon leadership to provide the culture that allows it to thrive. Collaboration, meetings like you're having today to bring together in your community a discussion about quality, but collaboratives that look at data together collectively and judge performance are essential to actually bring the quality improvement alive. And then finally, surgeons really have to be in the front leading, whether it's in the operating room or on Capitol Hill or in their classrooms. Now, if you look at where we're going in quality, I think we're heading toward two primary targets. The first is to create real value, and that's going to require better understanding of cost data and linking dollars to quality. We're in the infancy of that, but that's coming. And the second goal, I think, is really high reliability. How do we consistently do something that we intend to do in a regular fashion? And we do that through a number of techniques: study of positive outliers, collaboration, the culture, and ultimately even public reporting. So there are a lot of things that are coming forth that are going to push these two goals of high value and high reliability. What we're going to be measured against, there is consensus on today, and these are the four things that are within the law, but they're really things that people are focused on, and they are traditional measurements of quality, so structure, process, and outcomes, safety, preventable harm, particularly around procedures and infection preventable problems, resource use and appropriateness, probably the least developed in many regards, but a real opportunity going forward, and then finally the patient's experience of care. So as we think about what we want to be measured against, we need to keep these things in mind. Now, this may be the most important slide I show you, and this is a slide from the NISQIP program, and it's simply a graph, a so-called caterpillar graph, plotting the performance of different hospitals against some outcome. So this could be surgical infection, this could be DVT prophylaxis, this could be anything you can imagine. And when you get a graph like this, on the right in red are hospitals that are performing less well than expected. In the green on the left are hospitals performing better than expected. If you are a CEO or a chief of surgery or an individual surgeon and you get a graph like that and you're in red, what do? Everybody in this room says, what can I do to change my behavior? What can I do to get into the green, or at least to get out of the red? And that's the power of registry data and the power of data in general. And we have evidence that it actually works. If you look at the impact of this kind of reporting on 115 hospitals, the data is on the right there of the slide. Over a 2.5-year period of time, complications were reduced by 82%, mortality by 66%, and it was a believable number. It was about one complication per day in a 400-bed hospital or so. So this is real. This is probably the most important thing that quality measurement can do. And it's also linked to costs. And if you attribute $10,000 or so to a complication, using those numbers as a target for reduction, an individual hospital can save between $3 and $5 million a year. You translate that across all the hospitals in the United States, and you're talking somewhere between $20 and $25 billion. And so that's one very real thing that surgery can bring to this whole cost reduction strategy. Now, it is important to use clinical data, and this is why. This is a study that Cliff Coe did comparing NSQIP data to administrative data that CMS would, for instance, have. And what you see here is that the accuracy of administrative data for reporting complications or really judging quality way under reports. So that if you're interested in looking at quality assessment, this is going to be inadequate. If you're trying to put together a bundle of care so that you get paid fairly and anticipate the number of complications you might have, you're going to absolutely want to use more accurate data. So it's important for a number of reasons. And I think there's starting to be a real consensus that this is important. The collaboratives we've already mentioned are important, and there are now about 30 of these in the United States. We would love to work with you all to help you set one up in this part of the country. But what has been shown from these is you can reduce costs and get consistency in care. And what really comes out of this is a culture in an area where focus on the patient, focus on leadership commitment, what kinds of techniques can be used in a hospital to engage employees to participate. How do you create that so-called culture of safety? How do you use data to be transparent, and how do you then use that transparency to drive quality improvement? All of these topics are what are really probably the most important element of a quality program, and collaboratives are starting to learn from each other and adopt same practice. Finally, the culture has really got to be a little different than our traditions in surgery perhaps in the past. It can't be blame-free, certainly, but it certainly needs to be just and not punitive. And I think we all know what that means, but really how we learn and how we adopt this, I think, is really important, because it's going to allow quality improvement and our willingness to look at data and be honest about it and then use it as a basis for improvement to be something that becomes routine and not something that we have increased stress over. Ultimately, this is what's behind this concept of high reliability. If you look at the high reliability industries in the country, and we point to the airlines or the nuclear industry when we talk about this, they really have 5 simple steps that are behind their ability to achieve this. And one is the commitment to improve performance. The second is to have a simple technique applied in a standardized way. The third is to have data to inform that performance. And then the fourth and last is really to have accountability to performance. If you achieve that, you then achieve the principles of high reliability. And just as one example, we've reduced bloodstream infection in this country by 45% in the last 5 years by following these principles. So this is doable. There are hospital systems in this country today that are practicing with essentially no complications in things like bloodstream infections. And when you see that, you have to say, what are they doing that I could be doing in my hospital as well? Now, the surgeon of the future increasingly is going to be a part of a team. They're going to be parts of systems. I think you all know that. I think Salt Lake is a great example of that, where you have led in many regards with the systems of care that you've created in Salt Lake. We're going to be held to a standard of evidence-based practice. Ultimately, outcomes data, some of it's going to be publicly reported. So if this is inevitable, then what we really want to do is help be part of choosing how that's done. We're going to have to emphasize leadership development and engagement in a way that we have not in the past. But if you look at the high-performing systems, this is what they've been able to do. And it has implications for educating our staff in a number of things that are not as traditional, perhaps, as we've thought of in the past. The college is putting together a set of standards for quality improvement. Dr. James actually has helped write one of the chapters, as have some of the rest of you. And this we hope will be out mid-year this next year. But it's really an attempt to try and help everybody with these principles. And ultimately, we might be able to turn this into an external peer review program as well. We'll see how that goes. Finally, this is a slide that Tom Russell gave me 4 or 5 years ago when I just started and took over from him. And I think it's an important slide because I think it does represent the cultural change that we all have gone through, particularly trained in a previous generation. And historically, we were about autonomy and authority, and that's very important in surgery. It's very important in the operating room. But we also know that we need to be collaborative and evidence-based. We need to be transparent, and we need to be committed to measurement. And it's really a shift in our professionalism to being more accountable. And I think that we would all agree, this is where it's going. Finally, just to, again, thank you, but also to celebrate what you all do every day, we want to just share a little video that sort of summarizes why surgeons perhaps are a little bit different, that they truly are driven by these principles.
It's a genuine privilege to introduce our keynote speaker today because not only is he extremely well known for his role in quality nationally and is a biostatistics leader, he is also a surgeon, so we're really fortunate to have Brent as a local resource. Dr. Brent James is the Chief Quality Officer and the Executive Director for the Institute for Healthcare Delivery Research at Intermountain Healthcare. He is actually known internationally for his work in clinical quality improvement, patient safety, and the infrastructure that underlies successful improvement efforts. Brent is the director of the Intermountain Advanced Training Program and Clinical Practice Improvement, which I know several of our residents and a number of our faculty at the university have participated in, as well as other folks out in the community. He's a member of the National Academy of Sciences Institute of Medicine and has faculty appointments at the University of Utah School of Medicine, the Harvard School of Public Health, and the University of Sydney, Australia School of Public Health. We are, like I said, tremendously honored to have Brent participating with us today.
Thank you very much. I was asked to mainly talk about value today and thought I would start just with the formal definition of value. Could you give me the next slide, please? And then the next one, page down. There we go, one more. You're probably familiar with it. It's just clinical and satisfaction outcomes divided by cost. Outside of the concept, a not very useful definition. You know, I spent most of the spring of 2009 in Washington, D.C. I was asked to testify twice to Senate Finance, where the real power for policy in health care rests in the U.S. government. Once to Ted Kennedy's Health, Education, Labor, and Pensions Committee, once to House Ways and Means and Money Guys on the House side. More than that, I spent literally weeks of time with the senior staff of those committees. That's where the real action happens. It's where all the issues are identified, the debates take place really, the legislation is actually crafted. We had two issues on the table. The first was roughly 50 million Americans without health insurance. It just seems wrong that would hold true in a country like this. The other, though, I tried to convince them that we ought to focus on that cost piece first. Costs were destroying the country, basically. The truth is, what we got in the ACA was almost all insurance reform. The health system reform, the cost controls are quite weak compared to the insurance reform. Happily, I don't think it will matter. The reason is the private system is stepping up. I want to just show you a couple of implications, though, of the failure to address cost directly. These are things that are contained within the law. The ACA anticipated dramatic cuts in payments to hospitals and physicians. These are all government-generated figures. They're 2012. It's Foster's office at the Department of the Actuary for CMS. This is private health insurance payment rates, Medicaid, Medicare payment rates to hospitals dropping dramatically. It's starting to become quite real. This is from Avera Health, actually, put it all together. They listed all the current CMS programs to reduce payments for Medicare patients. For example, just this month, we have hospital-acquired conditions kicking in. The law requires that the bottom 25th percentile, the bottom quarter of hospitals on that ranking system take a 1% payment cut for all of their Medicare care delivery, just as one example. When you total it all up, this slide is now missing a couple of elements, just over a 10% payment reduction to hospitals for the Medicare that we deliver relative to private health insurance. Lest you think it's just hospitals, this is the projections for Medicare payments for physicians under the ACA. This was done to balance the budget. The President asked that we keep the additional deficit spending to less than $1 trillion in additional deficit spending through 2020. And one of the main mechanisms they did that was just assume that we could cut payments to physicians and hospitals rather dramatically. I don't know, what would you do if the payments you receive for Medicare patients dropped to half of what you're receiving for Medicaid patients today? What would that mean to your practice as more and more people enter the Medicare program? Now, interestingly, nobody believes that these projections are real. This is what is contained in the law. Nobody believes that they're real. It's completely unrealistic. It's the reason the sustainable growth rate keeps getting kicked down the road year after year. If they put this in place, we'd have a lot of patients with an insurance plan, a Medicare card. They just wouldn't have any physicians or hospitals. We couldn't afford to deliver the care to them, we'll see. Now, in the face of these pushes, though, it's hitting and it's hitting hard. And it's going to continue to push for the rest of our foreseeable future. It's going to be mainly focused around cost of care. There are two ways that we have traditionally come up with for addressing those sorts of things, two main coping strategies. Traditionally, in a fee-for-service system, we focused on top-line revenues. Do more. Do more imaging, for example. Do more lab tests. Bring in that new technology, unproven, but still high margins for that surgical robot, let's say. Build the new heart hospital. Bring in that superstar physician. Of course, the impact of this is to dramatically increase the cost of health care for the country as a whole. And it provokes a very predictable pushback. There's another way that you can do well financially, though, and it's to shift your focus to bottom line costs. Some years ago, a colleague and I, Dr. Lucy Savitz, got a little grant from ER-ICU. We tried to take Ed Deming's quality ideas. It defines waste in a very broad way. In our case, it would be anything that's non-value adding from a patient's perspective. We came up with a 6-part model, which I really like, of course. I created it. We could find national measures for 2 of the 6 categories. Now, the other 4 were non-trivial. They were the 2 biggest, but the other 4 were real contributors. On the basis of those 2 categories alone, we estimated that more than 50% of all money spent on healthcare in the United States today is technically waste. Non-value adding from a patient's perspective. 50%. That's more than 50% this year of an almost $3 trillion spend in this country on care delivery. If you believe this figure, it's a $1.5 trillion market capitalization rate. A huge upside. And the interesting thing is, you get the waste out by delivering higher quality care. You see, somebody's going to figure this one out. And when they do, they're going to create massive value for our country and for the American people. They're going to do very well indeed. The idea of higher quality driving lower cost. Now, in that context, just one idea. It's evolved over about the last 20 years. It's a method for managing clinical care. It happened first in 1991 at LDS Hospital in Salt Lake City under the hands of Dr. Alan Morris. It's been around for a while in the context of a large randomized controlled trial. Sometimes today we call them bundles. This is a detail of what it looks like in very short order. Number 1, you identify a high priority clinical care delivery process. Then around that process, you build an evidence-based best practice protocol. It turns out that that's ripe with difficulties. All sorts of problems in building an accurate protocol. You can argue that no protocol perfectly fits any patient. And the evidence would support you strongly in that argument. Do it anyway. Do it anyway because of what happens next. Step 3 is perhaps the most important. You blend it into clinical workflows so that it doesn't rely on human memory. This is not a matter of doing grand rounds, training everybody in the method, then expecting them to do it from memory. In today's complex environment, if you do that, you'll get reliability rates of about 50%. We'll get it right about half the time. Clinical workflows takes the form of standing order sets, checklists, patient worksheets, flow sheets, clinical flow sheets. Within Intermountain, we have about 20 tools that have evolved over the years for this purpose. Basic idea, doctor, just let it happen, full automatic, be lazy. What you get is evidence-based best care, you see. Now, in parallel with that clinical workflow, embedded data system, the data system is going to do 2 things. It's going to track variations from protocol. It's the finest variation measurement system the world has ever seen, frankly. And number 2, we need to know what happened to the patient, short and long-term clinical and cost outcomes. A principle, no abstraction. Typical chart abstraction has a 20 to 40% error rate. When skilled clinicians who actually delivered the care evaluate what the abstractors thought they found, if you build it incorrectly without a burden, the clinicians who deliver the care will record the care as part of a clinical documentation system. Step 5 is the most interesting to my mind. I'd say it this way to a room full of surgeons. Ladies and gentlemen, it's not just that we allow or even that we encourage. We demand that you modify our shared baseline protocol based on individual patient need. I have strong evidence that I can't write a protocol that perfectly fits any patient with rare exception. And doctor, that's why we have you. We need a thinking person at the interface who's going to choose what needs to vary and how it varies for this individual, you see. In a very real sense, this is the opposite of cookbook medicine. In fact, I would argue to you that it's how I learned surgery in my residency. I had a standard process I used for every case. Made me faster, I didn't forget things. I expected to reach my hand back and have a nurse slap the right instrument in my hand without a word being said. This idea is not new to medicine. In fact, it's defined good clinical practice for the last 60 years. Oh, there's only one difference. Instead of me having my process, Mark having his, Sam having his, Amalia having hers, when you're working in a shared environment, you need to have a shared process. It means your staff can support you much better than they would otherwise. It drives up your sample size, and it makes it possible to learn from one another. And it's associated with dramatically better care. Last step is in some ways the most important, down here at the very bottom. You take the data, variation data and patient outcome data, and feed it back to the team in what's technically called a lean learning loop. This is the core of the learning healthcare system. I serve on that IOM committee. That's the core of it. And your protocols change dramatically over time. Even if I start with something that's highly questionable, in relatively short time you can start to drive something that has validated outcome data behind it around best care driven by a group of thoughtful professionals under the transparency of a good data system, you see. But that's the core model. Now you need to know it works. Just one example. The main cause of death in any modern hospital in the United States is sepsis. About half of those cases come in through the ER. This is Dr. Todd Allen in the ER, Dr. Terry Klimmer, one of our lead intensivists in Utah, put together a protocol for the very aggressive detection and treatment of sepsis, ER following through to the ICU. This shows protocol compliance rates overall. It's that feedback loop, tuning the thing over time. This is across a 4-year time period. Now nationwide, mortality for that condition ranges from 20 to 50%. When we started, we were pretty good. We had a 20.2% mortality rate. Oh, it's now been 3 years since the 4 biggest tertiary hospitals in Intermountain went over 9%. A new standard for sepsis care. This one's about 125 lives per year, is what this one produces. Oh, I have more than 100 of these, where process management has dramatically improved clinical outcomes. So the first big takeaway I want you to hear, we could be much better in terms of the service that we provide to our patients in their hour often of greatest need if we were willing to work together as a professional team, supported by good data. I like to say it this way, literally, we count our successes in lives. In Intermountain, I can document more than 1,000 lives per year of people who a few years ago would have died who don't today. And you understand that mortality is just the tip of the iceberg. Think of what that means in terms of suffering averted, function restored. It's a much broader impact than just the mortality rates that you see. Second thing, it nearly always costs less. These are the actual cost data. That is currently saving about $700,000 per year in operating margin for the Intermountain system. Nearly always better care is cheaper care. Not always true. Some cases it's more. Deming gave us the tools to identify the exact circumstances in a precise way. Well, I think you get the idea. I predict that we're going to see healthcare in the next 10 years stand on its financial head. You're already seeing it dramatically across the country. It has to do with value. In the past, we've focused on top-line revenue enhancement as a way of running a practice. Quality was defined as regulatory compliance. It's what somebody else did to us. We were required to submit those data. It was a burden, a lot of pushback. My prediction is in the future, quality is going to become your core business strategy. It's going to be where you live or die as a professional and as a practice. That process management is going to be what determines the people who live from the people who die professionally. Process management is the key. Higher quality drives lower cost. Now you're going to have to align financial systems, frankly. It's why fee-for-service will die. You are able to manage the care. Whoever takes the financial risk gets the benefit. I didn't put it in. I could show you how you create windfall savings for purchasers. For us, in tens of millions of dollars, where insurers, federal government and other insurers, get windfall savings from our good activities, and we are financially punished under fee-for-service payment. And as you become competent at this, what it makes you want to do is manage the money too, and pass some of those savings through our patients while protecting the future of our profession. Well, with that, just to echo Dr. Hoyt, better has no limit. It's the duty of every generation of the healing professions to pass along something better than we ourselves received. We're unique in that regard. It's been about 100 years since the healing professions went through this size of transition. It's our duty to create that next world, a far better world than we ourselves received, and ensure the success of our profession and the service we deliver to the people of this country into the future. With that, Dr. Hoyt, thank you. And back to you, Amalia.
The next portion of our program this morning is going to bring in that panel that I alluded to first thing, with very diverse group of folks who bring a lot of different experiences to us and a lot of different perspectives. What I'm going to do right now is just give you a brief introduction to who our panelists are this morning. You all have longer bios on everybody in your program booklet from today, so if you want to dig into who they are and what they do a little bit more, it's there and available for you. And what I'm going to ask is that for each of our panelists, that once you come up and make your remarks, if you don't mind staying up front, that would be great. I won't make y'all come up right away. Our first panelist who will be speaking will be Dr. Vivian Lee. She's the Senior Vice President of the Health Sciences at the University of Utah, as well as the Dean of the School of Medicine. She's the CEO of University of Utah Health Care as well. She's a radiologist by training, has a very extensive research background as well as her clinical profile. After Dr. Lee will be, is Charles next? I apologize. There we go. Charles Sorensen, who's the president and CEO of Intermountain Healthcare. His clinical background is as a urologist. Dr. Mark Mariani is an orthopedic surgeon who is in a group practice that is based at St. Mark's Hospital here in Salt Lake City, with a practice in adult reconstructive orthopedics. Following Dr. Mariani will be Dr. Sarah Hartsaw, who graciously has traveled from Gillette, Wyoming to spend time with us today. She's a general surgeon as well as the owner of High Plains Surgical Associates, and she's the chair of the Board of Trustees at Campbell County Memorial Hospital in Gillette, Wyoming, as well as being a lieutenant commander in the United States Naval Reserve. Timothy Anderson is an attorney with Jones Waldo in St. George. He is also a member of the University of Utah Healthcare Board of Trustees and is here representing the perspective of both board members and community, non-physician folks. Dr. Sam Finlayson will be next to last. He's the professor and Claudius Gates and Catherine Gates Presidential Endowed Chair at the University of Utah, as well as being the chair, the Department of Surgery chair for us. And batting cleanup will be Mark Ott from Intermountain Healthcare. He's the medical director of surgical services at Intermountain Healthcare and is also an adjunct faculty member for the University of Utah General Surgery Training Program. So with that, I will bring you Dr. Lee.
Well, good morning, everyone. It's a real pleasure to be here today, and it's really an honor to join such a distinguished panel and keynote speaker. It's a pleasure to be here. Amalia mentioned that I'm a radiologist, and I do MRI. But I just have to confess that I started out as a surgeon, so I hope you'll adopt me. I started out in surgery at Duke, working with David Savison back in the old days, so I have a few stories. But I'm delighted to be here and to share with you some of our thinking about the transformation of an academic medical center from volume to value. And I really have to applaud Brent James and the work at Intermountain for really leading the country in helping us think about how to make this transformation. We share that same formula that value is quality or outcomes and patient experience divided by cost. And so I thought what I'd share with you today is our journey in that transformation in two parts. The first part is really focused on the patient satisfaction piece, which started about 7 or 8 years ago under the leadership of my predecessor, Loris Betts. And then the more recent part, which is really trying to tackle the quality and cost piece together with our value-driven outcomes. So 2 quick short stories, because I know we don't have a lot of time. So about 7 or 8 years ago, Loris Betts, as I mentioned, my predecessor, the former senior vice president at the University of Utah, just really got fed up. He got fed up with patient complaints, with the letters that he was receiving in his office, with the people who would stop him at the grocery store and say, you know, I came to the ER and it took me 7 hours to be seen, or, you know, the attitude of your staff wasn't so good, and so on and so forth. And then the final straw was his wife came in to the health system. Same last name, so you think we would have figured that out, but did not get the best treatment. Good care, but not the best attitude. And so he launched what we call the exceptional patient experience. And he really challenged the organization to say that we can't be a great medical center if our patients don't think we're great. And that started a journey, as I said, about 7 years ago that has served as a very useful algorithm for us for thinking about transforming an entire medical system. And what started, how we started it was first to assemble a team of people to focus on the patient experience that included a lot of patient input. And the second step was to develop the data and the metrics, very much like the ACS scheme that David Hoyt showed earlier, and to start to survey all of our patients with a very simple Press-Ganey questionnaire that really focused on professionalism, on communication, and on patient engagement. And so every patient, inpatient or outpatient, would receive that survey, first by paper and then now electronically, within 24 hours of their visit. And we fed that data back, very similar to those kind of data charts that were shown earlier. In this case, they're red and green dashboards, to all of our providers, to give them a sense of where their patient satisfaction data positioned them relative to the national benchmarks. So everybody got these dashboards, and you can see in red and green on your dashboard how you did compared to a national benchmark, your peers across the country in patient satisfaction. And consistently we saw, as you all would imagine, you know, physicians are really terrific self-learners. Everyone improved with that data. And we had teams, SWAT teams, I guess we might call them, who came out and helped practices and helped individual clinicians and their teams to try to improve. We did some system-wide improvements to address common causes of complaints, like we instituted valet parking for all of our patients, so that helped everybody move up. And then gradually we increased the transparency of that data. And with that transparency, we started to allow each provider to see other providers, so the names weren't blinded anymore. You could see how you were doing compared to your peers, how you were doing in cardiology compared to orthopedics, compared to rheumatology. And then finally, about a year and a half, almost 2 years ago now, we took the final step, I think, in transparency, which was we posted our patient satisfaction scores online. And so now if you go on to our website, the usual Find a Doc website that most systems have, and you click on any of our providers, Amalia, for example, you can click on her, and you will see that very familiar 5 stars that you would see with Amazon or TripAdvisor, and those are the Press-Ganey data from our patients, the true data, including all of the patient comments. We only posted it after we had a lot of internal discussion and everyone got a lot of advance notice that we were going to be doing that, and again, we saw another improvement. And so we're very pleased that in the last round of Press-Ganey data, again, all the national benchmark data, about half of our providers, 46% of our providers, are now in the top 10 percentile nationally in patient satisfaction, and a quarter of our providers, that's 1 in 4, are in the top 1 percentile nationally. So we're very pleased with that. I think it's very satisfying for our providers to get these compliments and to have very satisfied patients. And of course, it's good, really, really great for our business. And we also really are committed to providing patient-centered care. And one component of that is certainly their degree of satisfaction with their experience with us. And that experience, as I mentioned, set the algorithm or gave us kind of the foundation for how to think about the rest of the transformation, to really focus a lot more on quality and the costs that were required to achieve that quality. And it's not as if we hadn't been working on quality for a while. As you may know, the teaching hospitals across the country are part of something called University Health System Consortium. It's about 130 teaching hospitals in the country, university systems, and we've been very pleased at the University of Utah to be in the top 10 for the last 4 years in a row there. But there's always improvement, as Brent's last quote suggests, and so we continue to try to work on that. So about 2.5 years ago, we developed a similar kind of tool. We had the same kind of experience or same kind of idea in mind as we did with the exceptional patient experience, and now we said, well, what if we put into the hands of our providers value data? What if we gave each and every one of you data that would show your outcomes, your outcomes for whatever procedure, whatever DRG, ICD code, whatever, against the actual costs that it required to achieve those outcomes. And when I say costs, I don't mean charges. I mean, what are the actual costs for the health system to deliver that? What are the costs in terms of minutes in the OR, minutes in the ER, MRI scan, whatever, the actual cost of delivering care? And for us, the cost part was the most challenging because we already had data on things like supplies and pharmacy, but we did not have cost data on labor, professional services. Those things were much more difficult to work out. So that's taken us a while, but we've developed those tools. And now with our value-driven outcomes tool, we have outcomes against costs for every provider, diagnosis, division, code, ICD-9 code, you name it. And we've just had a pilot rollout in the last year, and our goal in the coming year is to really get it into the hands of all of our providers, because I think the take-home message of what we've learned in this transformation is a piece that has been very much, I think, neglected in the national discourse, which is the solution to the transformation is in your hands. The solution is in the hands of the providers, the frontline clinical teams. And I think too often when we're talking about the transformation, we think about it at a hospital system leadership perspective or from a Medicare, Medicaid, CMS perspective, and we really have neglected the fact that the true power of transformation is in your hands. It's up to you to change your practices, to define what value is for you and for your patients, what those critical outcomes are for you that you want to be measured against. And then with those data in hand, I'm completely confident that we will be able to start to realize some of those 50% savings that we're all striving for in healthcare. So with that, I want to thank you very much for your attention today and to say how privileged I feel to be a part of the Utah community. One of my favorite slides is a chart that shows all 50 states, the healthiness against the costs of care, and we're very privileged, I think, here in Utah to have that sweet spot position of being among the healthiest at the lowest cost, and I think you all deserve the credit for that, and it's a real honor for me to be a part of this state. So thank you very much.
Well, thank you. I, as Dr. Lee did, want to express my gratitude for you all attending with your interest in this important subject, and I'm honored to be part of the discussion today. So I was asked to give a little overview of our journey on quality at Intermountain Healthcare, and I realized as I was sitting there that I'm, by a little bit of a margin, the oldest person on the panel. It's a very distinct privilege I have, I guess, but I have been around long enough to see this journey at Intermountain Healthcare, and it's an appropriate time for me to express thanks to people, some of whom are in this room and others aren't, whom tremendously impacted on my ability to take better care of patients and to feel a greater sense of personal satisfaction in this wonderful career of surgery. And just thinking back, it began with some extraordinarily capable surgeons who were at LDS Hospital before I came. Among those were Dr. Russell Nelson, Dr. Kent Jones in cardiac surgery, Dr. Larry Stevens and Dr. Richard Price. I'm pleased that Dr. Price is here today in general surgery and trauma surgery, Dr. Price, as well as Dr. Terry Clemmer, who was mentioned, who's, although not a surgeon, worked so closely with us in the care of critically ill patients. And each of those physicians who were mentors to me were people who were very careful in the processes they used in surgery. It was never willy-nilly. It was always according to a protocol that you varied when there was a reason to do that. So that was one legacy. The other remarkable legacy came from a man named Dr. Homer Warner, who was one of the real pioneers in medical informatics in the world, and beginning in the late 60s and early 70s, established a remarkably capable clinical information system that did two things. One, it certainly tracked the patient's experience both from the standpoint of what was done to the patient and the outcomes, but also the cost outcomes. The second thing that it did is very early on, Homer wanted that system to help in medical decision making. So it was used early on, even in the late 70s, to help us in clinical decision making, and later on in the 90s in very complex decision making, as Brent mentioned, in things like the management of a ventilator for a critically ill patient with ARDS. So with those two things as a background, we went along, we're making improvements, but the next really quantum step came in the late 1980s. At about the time Brent James arrived from doing his statistical work and all at Harvard, after he spent some time as a surgery resident, he decided he'd go off and try this for a while. It seemed exciting. And he came back to Salt Lake, and it turns out that our little group of urologists at LDS Hospital were young Dr. James' first patients or experimental subjects, as they arrived in our division meeting one morning at about 7 o'clock and said, we've got all this data on your performance, doctors, on doing TURPs, which is a commonly done, probably too commonly done, not probably, definitely too commonly done operation back in the 1980s. And they had data that had been collected over about a year on all the urologists at Intermountain Healthcare on how long it took us in the operating room to do a TURP, how many grams of tissue was resected during surgery, how long the catheter stayed in, blood transfusions, if any, were necessary, length of stay, and cost. And as you would expect, there was a big deviation. Well, I can very well remember our response when these people who none of us knew, none of them were urologists or experts like we were, came and presented this data. I think we were an example of Kubler-Ross's stages of grief. You know, first it was shock, and then it was anger, and then it was despair and wailing and blaming other people. And finally, we came to acknowledgement that maybe the data worked. The reason I want to bring this up is it was Brent's style back then, and I've never forgotten it, and we've tried to always do that at Intermountain, is that he didn't come and say, I've got the answer for you. He came and said, here are the data. What do the data teach us? And then, of course, our first response is, well, the data is bogus. And he said, okay, granted it's not perfect. How can we make that data better? And so then we'd kind of dig into it, and, you know, to our shock, actually the data was pretty accurate. So that led us to having some conversations one with another to say, you know, some people who were leaving catheters in the patient in for a week, or almost 5 days, they'd say to somebody else who took it out the next day, how can you do that and the patient doesn't bleed or die or something? And these conversations happened. And what we saw is we still had a bell curve of distribution a year later, but the whole thing had shifted to the left toward better outcomes, better clinical outcomes at lower cost. And Brent's idea is we're not here to cut off people who we define as bad doctors. We're here to help everybody learn from one another and improve. That was such a powerful lesson to us at Intermountain Healthcare, and to me personally, and it's been something that I've always tried to do in my own practice ever since then. So, as I mentioned, when we look at the data, which you just have to have if you're going to get better, what we've found at Intermountain over the years is if you have objective data on outcomes, when you look at it, what we find, maybe you won't find this, but what we've found is we're never as good as we thought we were. It's kind of embarrassing, frankly, because as surgeons, we kind of remember like our last 5 or 7 cases, and we think we're doing well. But if you look at it over time and compare it objectively with how other people can do consistently, most of the time we find we have room for improvement. And as Jim Collins wrote in that book, Good to Great, one of the important principles of getting better is to confront the brutal facts. So the data that Homer's clinical information systems provided us help us confront the brutal facts. The second thing that I learned from this data and this journey to improvement is how grossly most people underestimate, even people who are in healthcare and even doctors, what a powerful incentive and motivator it is for us as physicians to be able to look at objective data, as Dr. Lee talked about, and say, we've made this improvement. And now in these given areas, we're performing among some of the best in the country or maybe even the world. That's a very powerful motivator to each of us who went to medical school wanting to do the right thing for our patients. So as we continue on this journey at Intermountain Healthcare, we remember Dr. Terry Clemmer's comment, which was quoted by Richard Bomer, who's a professor of management at the Harvard Medical School, in an article he published in 2012. He picked it out actually as he wrote a white paper on clinical improvement, and the little quote he had was at the very top of it. And Terry said, "We're not trying to control our doctors. We're trying to get our doctors to take control of the system." In other words, it's all of us as the physicians who need to be deciding those processes that we heard about at the beginning of this talk that involve caring for our patients. Now finally, let me just say a little bit about cost. I've been around long enough that I remember a time, and many of you do as well, when we were taught by example and often explicitly that we were not supposed to pay attention to how much something costs in the care of a patient. In fact, I can remember being told by a distinguished professor of surgery at one point that it was unethical for us to consider the costs. We were just there to do whatever it took to get the patient better. Now I think most of us in this room and most doctors generally recognize that we can no longer ignore costs, because the very best care in the world doesn't mean anything if nobody can afford it. So it's incumbent on us as surgeons to be concerned about the cost. Now, speaking for myself and probably for the rest of you, I think because we're surgeons, we like new things, new instruments, new ways of doing things. It's exciting. It has the potential to bring new capabilities through technology. But I think we need to be very, very careful as we implement those new technologies and see, are they really adding value that's commensurate with their added cost. I just think of my career when we first introduced exciting new ways of doing minimally invasive kidney stone surgery, and then shockwave lithotripsy at big cost, but at savings for the patient. And as we talked about prostatic ultrasound, and later as we moved into robotic surgery for prostate cancer, and then the ultimate, I guess, in terms of expenditure is proton beam therapy for patients with prostate cancer. But is it creating outcomes that are better than conventional therapy? There's not evidence yet to show that there is. But I think in my own practice, the most profound change in treating prostate cancer surgically wasn't a technical innovation. It was Dr. Pat Walsh at Hopkins who showed us a new way to do radical prostatectomies, that if you really paid attention to the detail of how you do that operation and do it consistently well, you can have tremendously better outcomes, both in terms of reducing complications and longer survival for our patients. And that's the kind of diligence that we as surgeons need to be careful to embrace, not just looking out for new technologies. So I'll conclude there and express again our thanks to each of you for what you're doing, and it's my pleasure to introduce Dr. Mark Mariani.
Good morning, everyone. It's a pleasure to be here. When I was looking at the agenda, I wasn't sure why I was asked to participate. I'm here to represent, I think, those of us who are actually on the front lines, actually seeing patients. My task is to discuss the effect of quality measures on the practicing surgeon. And let me just give you as a point of reference, let me point out where I'm coming from. It might help. And I'm quite surprised and quite pleasantly surprised to find out that my viewpoint isn't much different than the intelligent people who have spoken before me here. So I'm pleased with that. But I was at Mayo Clinic for 10 years, 5 years as a resident and then 5 years on staff. So I'm very familiar with that system and how they promote quality. I came back in 1989 here with a good friend of mine, Dr. Michael Bourne, and we started the Salt Lake Orthopedic Clinic, 3 of us with Dr. Robert Lamb. And we now have 15 partners and over 116 employees. So I understand how difficult it's been for us to continue to provide them with their benefits that they all want and deserve. We're an independent group and we're fiercely independent. And I have some strong feelings about that. But I need to point out to all of you that I love what I do. And I feel fortunate to be involved in patient care, which is where I spend 95% of my time. So my subsequent discussion here is not sour grapes. I'm really fortunate to have the practice I have. I have more business than I can do, and I'm very happy with it. So in theory, I think quality measures make a lot of sense, and especially if it's done in a cooperative manner with the surgeon or the physician. However, the problem is that increasingly, the surgeon and the people I see every day are feeling like they're being left out of the equation. Quality measures, core measures, surgical protocols, operating protocols, supply and staff are often dictated now to us rather than arrived at in a cooperative, interactive manner. Despite as physicians and surgeons literally controlling everything, and quite honestly being legally liable for everything, those of us who are actually in the trenches doing the work feel like now we control nothing. The intrusions in the name of quality into the practice of medicine, often by individuals who have never or are no longer involved in patient care, is making the practice of medicine ever more inefficient and frustrating for those of us who are actually doing the work. When did the hospital entities and the government feel like they need to decide the responsibility of quality care, especially the government? We all have institutions that we belong to on a national basis that dictate that and make us continue to do through medical education, maintenance of certification. PQRS, Sunshine Act, CME for MOC, Pay for Performance, JACO, EMR, eScript, pre-authorization, HIPAA, all of these things are associated with increased time, effort, and expense, particularly if you're in private practice. They don't add anything to quality. In addition, our services have been unilaterally devalued over the past 22 years. Surgeons' remuneration today for a given procedure is 30% less than it was in 1992. That's 68% less if you adjust that for inflation. These intrusions, I believe, are decreasing quality in a lot of different ways than what you've heard today. I see more discontent among my peers now than ever before. They're frustrated at work. They're feeling undervalued. Quite honestly, they're feeling underpaid, and they're feeling definitely underrepresented. Many physicians and new graduates are now opting to be employed rather than go into private practice. They're interested in a guaranteed paycheck and free time. They want to avoid the hassles of private practice. And some are doing it, quite honestly, out of financial necessity. Applications to medical school from 1991 to 2006 dropped by 20%. 10% of the total joint fellowships, what I'm involved in, did not fill last year, which is amazing to me because joint arthroplasty is among the most successful of surgical procedures in restoring patients to an active life. It's an unbelievably gratifying field to be involved with. And as baby boomers age, the demand will be doing nothing but rise, and the projection is that we're going to be at a decreased capacity to be able to handle that. Surgeons now are limiting the number of Medicare patients they see or completely dropping off the Medicare panels. And that trend, I think, will continue as Medicare remuneration continues to decrease. I think it's great to discuss quality measures, but how about discussing a system that I believe sets the stage for less than optimal quality care? Insurance companies and hospitals currently dictate health care. They dictate what physician a patient can see, and then they dictate which facility we as physicians have to utilize to treat that particular patient. The end result is seeing surgeons travel from hospital to hospital to provide care, often operating at multiple sites in the same day. I think it's inefficient, and it's potentially dangerous, and it leads to poor care. And we're discussing quality here today. They also dictate more and more the personnel that we're allowed to have in our operating rooms. Our OR equipment will come in one day and something's changed and we haven't been involved in that discussion. Even the choice of the prosthesis that I use today is coming into discussion, which is great. And I'm all for cost containment. We helped St. Mark's set a ceiling that allowed everybody to participate at a certain ceiling for the cost of a prosthesis. But the problem is now some people are trying to dictate what we use. I actually happened to be sitting on an airplane with an administrator who is involved in the supply chain of a hospital here, who told me that prostheses are, quote, just a commodity, and that you, meaning me, ought to be able to put in anything that we tell you to put in. As if he has a clue. This is a lay person with a lot of clout that's advocating that type of practice. It's still the surgeon who's in there doing the work. It's still us that are legally liable for all of it. And it's still us that have the outcome data that is going to be so critical for us moving forward. So what is the answer? Well, I believe the answer is similar to what has been discussed earlier today. But I believe in consumer-driven healthcare, which generates competition. And I think that is what creates efficiency, value, and quality. Patients should have the right to apply their insurance benefit towards seeing whomever they want. Then in turn, surgeons should have the right to operate at the facility where they can remain on site, utilizing the same staff and personnel day in and day out, developing the protocols used day in and day out with consistent staff that understand those protocols. Patients, I hate to burst everybody's bubble, but studies show that patients equate the quality of their health care by their provider, not by their health plan. If the various insurance companies and hospitals are as great as your advertisements say you are, then let the patient decide where to apply his or her benefit. And let the surgeon decide where to apply their skill. Competition breeds quality, efficiency, and cost containment. And if you don't believe that, just look at the automobile industry, the computer industry, and the digital music industry that we now have. Every one of you that has the fancy phone in your pocket, where would that be without competition? Where would Steve Jobs and Bill Gates, what would they have been able to accomplish if they had been forced to do certain things by government or a third-party entity? If you really want to look at the broad picture, look at East versus West Berlin. Quality measures have to apply to insurance companies and hospitals as well as to us. Hospitals need to be transparent in their billing as well. Why do hospitals continue to be allowed to have an artificially inflated bill for that which we do? The bill for a total hip replacement at St. Mark's Hospital is $50,000. Crazy. It doesn't cost half that. The bill, I have patients come in, I know the hospital pays $3,500 for a primary total joint, the prosthesis, but yet on the bill, $20,000. That's crazy. And it gives the public the wrong impression of what we're doing. Nobody pays that amount except for the poor person who doesn't have insurance or some of my patients who are self-insured. It's crazy to have that bill out there. And those bills need to be able to be viewed by patients online to see what the real cost is. Outcome data shouldn't just apply to the physician. Quality standards shouldn't just apply to the physician. Has to apply to the insurance companies and the hospitals as well. One only needs to look at Switzerland. They're the model for consumer-driven healthcare to see how well it can work and how well it does work. Clayton Christensen, in his book, The Innovator's Prescription, stated that, quote, "The system needs to be competitive, responsive, and consumer-driven," end of quote, and I believe that. Regina Herzinger, who's a professor at Harvard Business School, who wrote the book Who Killed Healthcare, which is a great read if you're interested, states that, quote, "Government control smothers competition under a blanket of uniformity, but it's the competition that will improve the quality of healthcare services and will create the best opportunities for cost control." She also writes, quote, "Dictating protocols to doctors is as meaningless as forcing artists to paint by numbers," end of quote. Consumer-driven healthcare, which isn't unlike that which has been discussed this morning, but I really believe that consumers ought to be able to have access to the data, have a benefit, and apply that benefit where they want. I think consumer-driven healthcare, rather than the current system of dictated protocols, would ensure quality, efficiency, and cost reduction. Thanks.
Good morning. I really enjoyed your talk because I thought I was going to be the cranky one, and you beat me to it. I'm also in private practice, and fiercely so. Several years ago, our previous administrator wanted to hire, well, we've had several administrators that wanted to hire everybody, and I've always thought that was wrong, and I still do, even though I'm chairman of the hospital board. I looked up the definition of value, which, as opposed to Dr. James, it said relative worth. And when Jill called me to talk about what I was going to say, I was pretty cranky to her and said, worth to who? Whose value are we talking about? Mine? The patients? The insurance companies? The governments? The hospitals? It's a pretty broad spectrum, and it's not the same for everybody. Same thing with quality. that can be measured, I'll give you that, but what I think is quality is not what the patient thinks is quality. The operation was a success, but the patient died. I think I did a good job. It wasn't, they died. I'm sorry. So that patient didn't get quality. As I was listening to all the previous speakers, I thought about, in my short lifetime, what changes I've seen in medicine. I worked in the hospital when I was in high school and in college, and at that time an open cholecystectomy patient stayed in the hospital 7 to 10 days. They didn't get out of bed for the first 2 or 3 days. I was a nurse's aide. We had to provide all the care for them. I don't even think they make bedpans anymore, but patients used bedpans. When I was a chief resident in Phoenix, in I would say February of my chief year, someone came and gave a presentation on laparoscopic cholecystectomy. The 5 chiefs looked at each other and said, "That is the dumbest damn thing I've ever heard of in my entire life. Why would you take a relatively straightforward operation, confuse it with all this crazy equipment, you can't get your hands on everything," and within 6 months we all had paid to go learn how to do that operation. So now a patient comes in, has a laparoscopic cholecystectomy, stays 4 hours in the hospital or in an ambulatory surgery center. I would bet that the cost or the bill is more in dollars, possibly even adjusted dollars, than it was in 1978 when I was working in a small hospital in western Nebraska. I don't know that, but I think that's something I might look into to find out. At my hospital, there are 3 general surgeons. We're all separate practices. I've been there the longest. The other 2 gentlemen have been there between 3 and 10 years. So I naturally think I'm the best surgeon. So I had them pull some statistics together again about laparoscopic cholecystectomy, because my concern was one of the new guys took forever to do a lap chole, and he never asked either one of the other 2 of us to help. So I thought there was there could be some teaching here that, with help you can be faster and this, that, and the other. And so they pulled all the data for me, and yeah, my times were 1 or 2 minutes better than the next guy, and significantly better than the guy I was concerned about, but my costs were higher, and I was appalled. I was so shocked. I was positive that because I had a shorter operating time, which to me, the operating room was the most expensive part, surely my costs would be lower, but it turned out they weren't, and when we dived down into it, it's because I do more cholangiograms. So they always had the cholangiogram stuff in the room. They always had it open. They always had the fluoro there. They always had x-ray there. Well, that just drove the costs through the roof, and I don't do that anymore. So I am teachable, slowly, but I am teachable. So that sparked a broader question of surgeons don't have the vaguest idea of what things cost. And as was said before, some of us were taught that it was irrelevant what they cost. Our job is to help the patient. But we started having these conversations, and some of the scrub techs got together and put up a bulletin board in one of the back hallways of various things: sponges, catheters, arthroscopy equipment. They'd have what everybody used, they'd stick it up on the board, and then they'd have what it cost the hospital to buy that and what the patient charges were. And as you say, the variation there is shocking. That a $5 cholangiocath, say, gets charged out at $25 to the patient. Well, that's nuts. But that's the way the system works right now. But we don't know that. So we can't find that out very easily. So those are some of the things that in my new schizophrenic life as chairman of the board, I'm trying to bring the hospital into figuring out where's the money going. We think we know that we do a pretty good job and that we're cost effective, but really we can't prove that. So our hospital board is, unlike most boards that I've come across, is publicly elected. So you run for election, it's a nonpartisan position, but you run for election every 4 years. So we have a very wide variety of people on our hospital board right now. I'm the chairman, which is their stupid move as far as I can tell. The vice chairman is a rancher lady. The treasurer is a loan officer at a local bank. The secretary is a physical therapist who used to work for the hospital, so he has some insight into what things should be. Then there's a local photographer who's been on the board for 24 years, a realtor, and a man who owns an oil field services company. So outside of myself and the physical therapist, quality doesn't, medical quality, surgical quality, it doesn't mean much to these other board members. And that's been a real challenge to try and get them to focus on it. I think the board in the past has been very focused on the finances. Our community is very fortunate that we have really good finances, and that makes us stupid sometimes because we can spend money on whatever we want. But trying to focus the organization onto the quality of care that we provide, and now trying to focus more on really what is this worth? What is this worth to the patients? What's this worth to the community? Can we continue to have a dialysis service when we lose $1.5 million every year on that? The answer is yes, because it's a community need. But what other things should we be providing? And that it's really been an education for me, and I'm enjoying this format so far because I'm getting a lot of good ideas of how to improve our quality, at the same time trying to improve the value to our community. So I thank you for asking me, and I look forward to the rest of the presentations.
I've been looking at this water with some interest for the last few minutes, so I thought I'd grab it. And in reference to Dr. Mariani's question, what am I doing here? That's a good question for me to ask too. But I was invited by Dr. Cochran and appreciate the opportunity to be here. I'm a lawyer with the Jones-Walda Healthcare Practice Group. I also head up the firm's international practice group, which means my day starts very early. I live in St. George, and when you're an international lawyer in Utah, you can live in St. George. In fact, when I'm traveling out somewhere in the distant part of the world and say, where are you from? And if I say Utah, I get this kind of scattered look. They're thinking, yeah, somewhere in the American West, near New Mexico or something. And but if I say, I live down between Las Vegas and the Grand Canyon, everybody knows where that is. Doesn't matter where in the world you are, they know those spots. But as part of the Jones-Walda Practice Group, I am a marathon runner. I started 13 and finished 12. I can tell you I do not know what the backside of an ambulance looks like. In fact, in my practice, I deal with healthcare governance and with regulatory compliance in a dynamic legal environment, and that's in large and small facilities and situations. So I greatly appreciate the opportunity to be here, especially to talk about these things. These are interesting times in healthcare. It's ideally a good time to focus on these things that deal with the factors that lead to really integrating quality improvement with institutions, the ones that we relate to, particularly to increase healthcare value. As I mentioned, I come to this table from a little different point of view as a lawyer, but much of my involvement in healthcare since it comes through the compliance side. It's arguable in this situation. It certainly relates to quality improvement, but it's arguable that it's an area that sometimes inhibits success and progress towards healthcare value due to the fact that so many of the hands that are in the regulation-making pot are not the hands of surgeons, nor are they the hands of physicians or providers at all. And I'll touch upon that further in a minute. In my volunteer life, I serve on the Board of Trustees of University of Utah Healthcare. And in this capacity, and earlier as a trustee of the university, I've had the opportunity to observe the tremendous impact of Dr. Lee, as she's really led the migration to a much more value-oriented healthcare delivery platform at the university. And as trustees, we also serve on various committees, and I serve with Dr. Robert Pendleton, who's our Chief Medical Quality Officer, as co-chair of the Patient Safety and Value Committee. And this committee includes the heads of the various medical departments along with certain key administrators. Now, Dr. Pendleton's a very extraordinary individual who works tirelessly, pretty much as a medical and a political scientist, really of the first order, in dealing with the evolving quality measures and their myriads of metrics, and really kind of the side streets, even some of the back alleys that affect us in this area, so that we really helps us as a healthcare system perceive how we're really doing. Now, I have a slide that I want to show you, and to give you an idea, and you can touch it again because I think the train even moves. I hope. Can you click it once more? There we go. To give you an idea of our adoption and interface with quality measures in our system, this is the illustration of quality metrics at the University Hospital since the early part of the century. You can see that this train clearly left the station in 2003. We had just 100 quality measures we were using. And now, at this point, we're almost up to 650. Now, for the healthcare quality industry, this looks like pretty good buy-in. And constantly fielding and implementing the methods of analysis, and some developed by the accreditation industry, others developed by government-directed programs. In fact, lots developed by government-directed programs, like the clinical quality measures, which help hospitals and providers encourage its behavior, sort of herds you to, and it's a herding process, herds you to meet stage 1 and stage 2 meaningful use certifications, so you can become, get really warm and friendly with the electronic health records. Or CMS's quality reporting for ambulatory surgery centers that relate to how you get paid. But also there's the private think tanks with their cores of statisticians, MBAs, and enterprise analysts who are likely tasked with turning out new forms of healthcare metrics, sometimes sort of like the software engineers at Microsoft. We're in a culture today where there's not a thing in the surgery suite, or in the hospital for that matter, that can't be measured, or at least we can't find somebody who will try to measure it and maybe come up with a software program to help. So when I say the train's left the station, I make note of a time when there was a station, but perhaps not too much of a train. The time was in the late 90s, when we generally considered the healthcare system to be the best in the world and doing fine, but then discovered that there was trouble, beginning in 1996 with the Institute of Medicine and other respected institutions really that concluded that our healthcare system quality was staggeringly poor and that healthcare was at odds with itself. Since that time, much has happened. We assume that there's been great progress, but do we know that for certain? To the point that Dr. Sorensen made, have we reached the point where good is good enough, or do we know what it is? Because it's perception of facts. The perception is not always the same as fact. Perception is not always the same as truth. In fact, there's a possibility, and only a philosopher can tell us, that perception will never be the same as truth. Now, we go back to discussions between Aristotle and Plato to go after that point, but that's kind of where we're at. Quality measures are indicators. They are perception, but they give us a picture of truth, hopefully, and that's what we look for in them. But there are many hard questions to ask, because as we position physicians, and in this case, today's discussion, surgeons in the middle of the quality measure effort, one thing that hasn't changed since the origin of the quality measure, or measures market as they sometimes call it, there's still only 24 hours in the day. So one question is important. Are surgeons being adequately compensated for their time in wrestling with quality management, with the quality management side of the healthcare enterprise? Now, just to finish out here, I have another illustration I want to show you. And you may wonder what this has to do with surgeons and healthcare. Have you ever been to a basketball game where you're on the opposite side of the court, looking over at where the teams are seated? Or you can sometimes watch it on television. A strange thing happens when a timeout is called. A group of big guys in suits stands up, managers, assistant coaches, injured players, psychologists, student assistants, ball boys, etc. And a lot of them even have clipboards. And they all gather around the bench, and soon you can hardly see the players. Now, they kind of disappear behind the people in the suits, as you can see us happening here. And regardless of what is said, and regardless of how well the grease board, how well the grease board plan is actually drawn, the players have to return to the court. One of these 5 players will need to come out and hit the 3-point shot. You see, the players are special. Only they can take the shot, and none of those fellows in the suits, regardless of what they say, are allowed to be on the floor while the clock is running. So I'd like to ask the parallel question. Maybe you see where I'm going. I'll ask the question, how many non-physicians, as talented as they might be, does it take to run a clinic, a hospital, a surgery center, a healthcare system? Not in any way to disparage the need for administrators, analysts, business managers, bureaucrats, politicians, lawyers, and so on. But the reality is that notwithstanding all of their intense interest, sense of duty, and understanding of the art and the science of it all, they are not the players. They're only on the sideline in the game when you, the surgeons, have to hit the 3-pointer with greater frequency than Jordan, James, or Johnson. Now, when we ask that parallel question, how many metrics is enough? We also need to ask the question, who's creating them? And maybe even the sensitive question, whether the quality measures industry has perhaps, to some degree, been hijacked by the non-physicians. Now, in closing from this critique, of the quality measures part of quality improvement in healthcare, it should not be assumed that I'm suggesting that quality measures across the board are either unnecessary or ineffective. Without them, we fly blind and back to the turn of the century. But to make it work, and it was pointed out, especially by Dr. Hoyt in his presentation, a great deal of leadership must be assumed. And so, I'd just like to say that I'm just a lawyer, so I'm not an expert in this, but I hope I'm not one of those guys on the sidelines that blocks the view. And I think it's fair, particularly in this setting, to ask the questions. At this point in the evolution of the healthcare quality, how many quality measures are enough? And the second question is, how many non-players are really necessary to keep a great team on the floor? Thank you.
Well, it's a pleasure to be here, and we've heard some great presentations. The only point that I would really take issue with was when the great 3-point shooters of the time were mentioned. Being from Boston, I have to point out that he missed Larry Bird. One of the. That's right. That's true. Okay. All right. So I understand. So when I leaned over to Mark earlier in this meeting and said, well, we get the last word. You and I are last, but unfortunately there won't be a lot of words left. There have been so many great points that have been made so far, so I will be relatively brief, I believe, and also in the interest of having more time for discussion with the group in this forum. I wanted to make a couple points. One is I wanted to give a little modest history of the quest for value in healthcare, and then I wanted to tell a story at the end. As has been mentioned here, and as many of you know, value is really seen as, or has been portrayed as, an equation of quality over cost. Sometimes quality, people add service, and there are a number of different iterations of what value is. I would posit that value is really any measure of the benefit of what we're delivering divided by the cost of delivering it, and that gets back to the earlier, 1950s and 60s work around cost effectiveness. Now, but we're just going to talk about value being quality or benefit over cost. If we look historically, back in the 1970s, when it became apparent that we really needed to focus more on value, really that value focus was on cost. In the 1970s, the HMOs were really developed and became a dominant feature of the healthcare landscape. But there was this relentless pursuit of driving down costs of care. And in the absence of addressing quality, oftentimes the drive to drive down cost was to the detriment of quality. And people noticed that. And we subsequently saw a dismantling of a lot of the organizations that had championed a cost-focused healthcare system. Then in the late 80s, early 90s, I think we kind of took a break. And in the late 90s, started to focus again on how to drive value in healthcare, but this time focusing more on quality. And the ACS has played a really key role within surgery, particularly by championing the NSQIP, which was of course invented in the VA under Shukri Khoury, but the ACS brought it to the private sector and championed it in a fantastic way. Now, the great thing about focusing on quality instead of cost in the value equation is that addressing quality simultaneously addresses costs. As was mentioned earlier, the better care tends to be the less expensive care. The next, now projecting into the future of where we're going with value, I would say that, yes, we've focused on cost, it didn't work. We focus on quality and we can simultaneously focus on costs. But I think that we need to, at this point, start to turn more towards what we mean by quality and really strengthen our understanding of what quality is. The NSQIP really sort of tried to put a corner on what quality was, as it's in the name, but NSQIP really only addresses one dimension of quality, and that's morbidity and mortality. The IOM has provided a definition of quality that includes care that is safe, timely, effective, efficient, equitable, and patient-centered. And NSQIP is really only addressing safety among those. We've heard echoes of this broader definition of quality today in many of the talks that have come before. Dr. Hoyt mentioned appropriateness, which is also part and parcel of effectiveness. Patient-reported outcomes being more towards patient-centeredness. Dr. Lee talked about exceptional patient's experience, and that really needs to be drawn into quality. And so if we look at the history of driving quality in healthcare, we've gone from early just focusing on cost to then focusing on quality, but particularly safety. I think the next stage is really fleshing out what quality really means and then driving it across the spectrum of healthcare. My second point begins with a story. Ray Price will appreciate this because this is a sort of a global health story. A couple of years ago, I was in Tanzania, and I was visiting a hospital and working with some surgeons there. And a couple of surgeons took me around the hospital to tour it, and we went to their ICU, which was a very small ICU. I think it had 7 beds. And there was somebody way in the back who was obviously really languishing. And I asked one of the surgeons, well, what's with the fellow in the back who's really languishing? And of course, Tanzania doesn't have HIPAA, so he told me all about it. He said, that's the fellow who has tetanus. And he's been in the He's been in the ICU for a couple weeks now. And I said, well, not seeing a lot of cases of tetanus. I said, what are his chances? What's his mortality? And the surgeon said, well, the survival's about 10%. And then the other surgeon said, 10%? No, he's going to die. Everybody with tetanus dies here. But that experience brought something to home, because as I toured around the facility there, I recognized that their resources were very limited. And by having one guy in the ICU taking up a bed for 2 months before he surely died, had a very measurable impact of the capacity of that system to provide care for their people. Now, in the United States, we have this tendency to think that the sky's the limit, that we can spend absolutely whatever we need to, and we can, if we need capacity, we build it. But it's becoming very apparent that our spending on healthcare is really unsustainable, and it is a real threat to the collapse of our economy. What the story taught me really is that every decision we make to provide care is a decision to withhold care. And if we make decisions that are clogging up our capacity and our resources with our complications because we haven't been good stewards of quality, we are in fact somewhere depriving somebody of care. High quality surgery is not only beneficial to individual patients, but is also an exercise of good social stewardship. And as parts of a healthcare system in the United States which does not have unlimited resources, we as surgeons focused on quality, we need to think not just about our patients, but also about this important stewardship. Thanks.
Well, the good news for what we're talking about today are really two facts that are just blatantly apparent. And the first is that there is so much waste built into what we do in medicine that we cannot help but shoot a bullet and hit something. And that's great, because there's no way we should fail at what we're trying to do. The second part is that I'm also very convinced from multiple examples that if we give people, specifically the surgeons and the doctors and the staff that they work with, if we give them good data, the vast majority of those people who want to improve will in fact improve. And so what happens when we give physicians more data and more participation and the staff they work with than they've previously had? Well, in the case of what happens if we have physicians participating with us with contracting decisions on how much we pay for supplies and what supplies we use? And I spend several mornings every week involved in meetings that revolve around this, and I can tell you that what happens is that the hospital systems get better pricing for the things they use. That immediately drops the cost to the patients. That's what happens when we get physicians involved in that. What happens when we give physicians, right where they're doing their work and the staff they work with, the cost of everything they use? And I can tell you from years of experience that immediately physicians continue doing the same operations but drop the cost by somewhere between 20 and 40% of almost every operation they do. Once they know their length of stays, the cost of their supplies, pharmacy, they actually change what they do, at least 85% of them. What happens when we let physicians help us develop care pathways that we then get everybody to agree to use for particular high volume procedures that we do? We drop the length of stay by usually 40 to 60%, and again, we see the cost go down in the same incremental fashion. And so it's very apparent that if we let the people who are delivering the care actually participate in all the aspects of care, not just show up in the OR, do the case, and go home, that they actually will change how we do it. So what about if we take the next step? What happens if we actually let the patients and their families participate in care? What if we gave them the information that, first of all, we've never had, and then secondly, we've never dared to share with them? And, we saw the effect of that recently in a study that Katie Russell and others did. And I think it's a wonderful example of collaboration as well. These were University of Utah surgeons who are working in an Intermountain healthcare facility using Intermountain healthcare resources and Intermountain healthcare data, and they took appendectomy for children. And they explained to the parents that for a non-perforated appendicitis in a small, otherwise normal BMI type child, that the outcomes would be exactly the same if you did it open or laparoscopic. And they shared with the parents that if we did it laparoscopic, it would cost substantially more, but with exactly the same outcomes. And they let the parents decide which operation they would choose. Surprisingly enough, the parents, who no parent would ever scrimp or cut corners on their kids. They might do it on themselves, but they wouldn't do it on their kids. The parents actually chose the less expensive operation. I think it was a finding that many people would have not expected, and yet it was overwhelming. The parents enjoyed the experience of being involved in the healthcare, and there was only a single-digit group of them who said they didn't want to be faced with that decision. And so I think it's a revelation that, in fact, we've never believed that the public could understand what we have to deal with, and yet they do. And I think that's really the big revelation in medicine, is that if we start having to share our data, our outcomes, our cost with the public, I really think that they would help us drive healthcare cost down and quality up, and that they could make good decisions with us. And yet we're afraid to do that. The thing that makes all of this work, the thing that is so important, is you have to have good data. You have to know that your numbers are right. And that kind of data only comes from large organizations like the American College of Surgeons and NSQIP and the things and registries. It only comes from healthcare organizations that are committed to mining their data and making it public to their physicians and to their patients and communities they work in. That's the key. That's why you need those organizations, is they can help you get better. I can work my whole career and I can learn one patient at a time. And when I retire or when I die, that knowledge is all lost. But if I'm part of a bigger organization, that knowledge helps the next surgeon and the next healthcare organization get better. Thanks very much.
We are going to bring everyone who has spoken to you this morning back up front, and this is everyone in the audience's opportunity to ask questions about things that you have heard this morning and what you've learned. And before we start on that, one of the things that I do want to point out is we have a lot of trainees here this morning. And please do not be intimidated if you are one of the residents or students here. If you've got a question, please ask that, because you are the future of surgery and what we're going to be doing and moving this forward. And so you all have potentially a more important role to play than many of us who are up here, quite frankly. So with that, a little bit to start with, I'm going to open with a question, and then I'll open it up to the audience. And this aligns with very much with what Dr. Ott was just saying, as well as what Tim mentioned and Sarah mentioned in their talks. How do we best educate the public, be it board members or patients and families? How do we best and most effectively do this regarding the different measures that are out there and the cost of things? Where do we start?
Well, we've been since my name was mentioned. I really liked what you said about the study where you had data to show the parents that no matter what you do, which operation you choose, your child will come out the other end the same. It's being able to have that information and the credibility, I think, to share with the patients especially. The other thing is, who's paying for it? When, as you said, you have patients that pay out of pocket for their total hip for $50,000, and that's what they actually pay, whereas your next three patients pay sequentially down to probably nothing at some level.
Sorry, I don't mean to interrupt, but I don't want people to be misled by that. The bill that is generated from St. Mark's for a total joint for everything is $50,000. Nobody pays that, including the patients that I have that are self-insured, because I go to the administrators and I say, they're self-insured, what will you do it for? It's $18,000. So, I'll stop at that. So I always work, and if they're uninsured, I do the same thing for the patient. But it just astounds me that hospitals, and you all do it, send out a bill that is so artificially inflated that nobody pays except for the poor person who doesn't understand the system, and they get hit with a bill that is just astronomical. It makes no sense. Sorry, I just want to clarify.
Thank you for the clarification. Where I was going with that is the people that are paying for their own personal care are the only ones that care.
Right.
If the insurance company, Medicare, Medicaid, if they know they're going to walk on their bill, sky's the limit. Load me up. I want every treatment you've got because I'm not paying for it. And that's a big difference.
Go ahead, Tim.
Well, I think that on best educating the public on measures, in the first place, when CMS first looked at publishing data and measures, they wanted to put it on the Hospital Compare website, and that was the plan, and that created a lot of paranoia and issues with regard to really for providers. Because what I think is that measures need to be put in the context of really what's meaningful to the patient, because the public is patients, and more importantly, that it needs to be based on data that is really vetted, that data that's stood the test of time, which I will also object to the 2016 rule by 2015 rule by CMS that they're going to start publishing data that's really not necessarily tested, but because it's being used for payment purposes, they assume it to be correct. And it's like the old adverse events reports. And I think that when that goes out to the public, it alarms the public. It's not good education. And so, for one thing, I think groups like this need to make sure that the patients understand, what really is accurate and reliable, and not just what's out there. Because in today's world, on the internet, anything can be true in 5 minutes.
David?
Well, I think we have to lead. I think it's time. I think the concerns that we all had 2 or 3 years ago about what the reaction would be were real, and I think there still has to be that concern. But if you look at the series of articles the New York Times has been putting together the last 6 months, they are doing the job for us if we're not willing to do it ourselves. And I think that the public actually, I think, can probably be trusted much better to use the data appropriately than we perhaps may think. I mean, this is really the whole point of that book by Michael Porter, is that the basis of competition, the basis of transparency is what actually does drive choice. And his point is that when medicine gets to that point, value will actually start to emerge. And so I think it's the biggest barrier to it are these concerns we have, but I actually think the concerns are probably much less than we think.
On 3 separate occasions, the Institute of Medicine has done evidence review around this topic. So the best was probably the Performance Measures Subcommittee, chaired by Don Berwick and Elliot Fisher some years ago. The evidence is overwhelming. Patients don't pay attention to medical outcome statistics when choosing a physician or a hospital. Right? 2 to 3% will pay attention. It may be condition specific for some very focused conditions, bone marrow transplant, they may. But in general, they rely upon relationship. Our conclusion was that in releasing information, statistical information to patients, our real target were referring physicians, not patients. And then a belief, an unsubstantiated belief, that release of those statistics would cause the health system to improve when it's released top down from that level, at the national level. That's highly questionable as well, just in passing. There are other ways to deal with those data besides actually improving the care delivery system. You can make an argument that it takes away from implicit value. Patients do respond to cost, but almost no patient sees the true cost of their care. Dr. Ed Hughes is a surgeon, trained at Harvard Medical School at Mass General. For the last 20 or 30 years, he's run the Center for Health Services Research at Northwestern University. Appropriately famous, internationally famous macroeconomist of healthcare. Ed likes to take the original book on competition, Adam Smith, 1776, Wealth of Nations. The basis for all market economies, there are 4 factors you have to have a market running, competition working. He points out that healthcare delivery buries the needle in the bad side. No market's perfect, it's just a question of how good you are on each of them. Buries the needle on the bad side on every one of the 4. The most prominent is insurance, which means that patients don't bear the cost of their care. And it means that markets are fundamentally impossible in the face of an insurance product. What you really have are insurers who are acting as surrogates on behalf of patients and groups. And that's the only level at which you start to get a market. So it requires a little bit more of a sophisticated understanding of the nature of the system and how people interact within it.
Sam.
This is an anecdote to illustrate what we just heard about patients not really paying attention to the data. When Bill Clinton went to get his cabbage operation I believe it was in New York, where there was public reporting of outcomes, he drove right past a higher performing hospital to go to a lower performing hospital.
Let's be more precise on this one, Sam. He went to the worst outcome hospital in the state. Now, the joke behind this is that Bill didn't know all about healthcare. His wife did, but
Oh, that's right.
it turns out it wasn't that at all. He had a consulting cardiologist who said, Mr. President, in your circumstance, this is the best program for you. And then the outcome statistics went out the window. It's just a classic example. The evidence backs that up pretty strong.
Right, and as everyone knows, he had a complication too. Some years ago, I read an article that was published in the Journal of Medical Decision Making that the investigators went out and interviewed the public about the use of cost data in making medical decisions. And what I found very entertaining was that their conclusion, written in these words, their conclusion was, there is not universal outrage at the idea of using cost in medical decision making, which I thought was about as guarded as you could get. You know, there is not maybe 90% outrage, but not universal outrage. And I think that is a vestige of what I was talking about previously of you know, the previous focus on being on costs, and really we need to transition to be focusing on quality. We should be willing to spend lots and lots of money on healthcare, but we can't be spending it on things that aren't delivering benefit to the patients. And so it's really, if we're focusing on quality and putting our resources into interventions that actually improve the health of our population, that's actually a good thing.
Jill is out and about with a microphone, so I would love to open this up to an audience question.
You know, while we're waiting for the next audience question, I just wanted to point out just an example of where I think what Sam's talking about really works is, again, on sort of a joint project between the University of Utah and Intermountain Healthcare, we recently looked at tonsillectomy. We looked at about 20,000 tonsillectomy operations over a 6-year period in the state. At every one of the providers in the state, there's about 85 ENT surgeons and other surgeons who do this procedure. And we showed every one of those surgeons, we invited them to a meeting, WebEx, that they could attend, and we gave them their own personal data beforehand, and we shared that with them. And in the meeting, we showed them that their cost versus their complications being returned to ERs, readmissions, anything else that we could measure in the state. And it was really fascinating to them and to us that your cost of surgery did not correlate with your complications. And in fact, some of the most expensive there's 5 ways of doing tonsillectomy, and the most expensive ways actually had the highest complications. And we talked with them about that and let them have that data, let them work on that for a while. And the one thing that we didn't have was what the patient's experience was with that. And so we're spending the next 9 months interviewing every patient that comes through an Intermountain Healthcare facility for a tonsillectomy in the state, or at least their parents, actually. We've been doing these interviews, and it's been fascinating to see what the parents think about that. And we told the ENT surgeons that we're going to reconvene them after we have the cost, the outcome, and the patient experience data, share that with them, and then we want to share it with the public. And it'll be interesting to see when we show the surgeons what happened with their costs and their complication profile if they chose to do a different method or not. I'm positive that some will, but many will not. I'm also positive that when we actually share that data with the public at some point, that we'll see a gigantic change in how they practice as well. Because I think that's the value of the public reporting of our data. It's not that the public will change so much what they do, but that it will change surgeon behavior. When they know, when each of us knows that what we do has to be evaluated by an uninformed public, I suspect that we will change to certain degrees how we do things. And we will probably, for the first time in our practices, have a better handle on overutilization than we've ever had before.
Tanya.
Yes, I just had a question to follow up on that. I mean, I agree very much with the comments that were made about patients have an implicit trust in who they're getting referred to. They still have that. And so I get very few questions on my infection rate, but a lot of questions on cost, especially the last couple of years when patients seem to be shifted to high deductible plans. They want to know how much they're paying out of pocket. So I was curious, I know at Intermountain we have a hotline the patients can call, but I don't know what that hotline actually tells the patient about the cost of an operation. But if there are comments from either Dr. Sorensen or the other health systems about, do they have readily accessed tools that patients can call and get an idea what their operation is going to cost?
Yeah, that's a great question, and it's really a point that I wanted to bring up is involving the patient. Mark, Dr. Ott could probably answer most accurately. I know that we have at Intermountain a price estimator for many of our services. I don't know how deep it goes into the specialty kind of, if you're doing a gastrectomy or on somebody or not, but that's something that we really need to have greater transparency. I agree with you. We're seeing that with our own patients in urology. More and more patients are saying, do I really need to have a CT to evaluate this renal cyst or an MRI, and I'm going to have to pay the first $1,000. Can we follow with ultrasound? And I think that's good. And I've always said that I think that most surgeons, most physicians are very willing to help our patients make wise decisions, including not only the medical decision making, but the financial consequences of it. And so we actually welcome this opportunity to talk to patients about this. And I agree with what was said earlier, that the intrusion of insurance where every dollar's covered makes everything free. And most people in healthcare, or patients, maybe many healthcare professionals themselves, have this false idea that the more we spend, the better health care we get. It's probably not at all correlated that way. But I just think in our involving the patient, we're starting to think more in terms of, instead of informed consent, informed choice for our patients. So, and what I deal with a lot in my continued clinical work is patients with prostate cancer. I think how different that is than it was 10 or 20 years ago. Now it's a question that you have to have some education of the patient. Should you have a PSA or not? Some people probably really should, and some people shouldn't. And if you have a PSA, if it's elevated, should you have a biopsy? Again, some should and some shouldn't. And if you find cancer on the biopsy, there's a big difference between finding a small volume, low-grade or medium-grade cancer and finding higher volume, high-grade disease. And then choices of what the therapy is. Is it surgery, radiation, or following the patient along? And I think that we're doing a lot better job now of involving patients at each node of decision making. And what we've found has been published in the National Urologic literature for a long time. Patients who are participative in the choices that they make in their care, including cost choices, no matter what they choose as the alternative, if you talk to them a year after the choice, they are happier than the patients who were just, put on the protocol, this is how we treat this problem. And I think that's the greatest potential we have in healthcare for engaging an untapped resource. That's involving our patients. And further, I just add, and then I'll stop. If we don't engage each of us as individuals on the front end in choosing healthy life choices and better manage chronic illness, there's nothing that all of us can do as surgeons, healthcare providers, to control the cost of healthcare in this country. Because each of us has to take greater accountability for our choices and how we manage our health and how we reduce our risk of having serious illness.
Dr. Hoyt.
Well, I just wanted to add one comment to the lack of concern because of insurance. I think, there's a very interesting article in Health Affairs this last year that looked at the cost of out-of-pocket for patients over the last 35 years. And that's gone from about 23% to about 11%. So that increase of 13% is being paid by insurance companies or the government right now. But you're starting to see them push back, and they're doing it through so-called tiering. But as tiering starts to emerge, however that develops, I think you're going to see patients much more interested in the cost of things than perhaps they currently are. They are relatively protected.
Next question, Dr. Lewis.
Hi, I'm Gia Lewis from the University of Utah, burn surgeon. So perception is the biggest part of patient quality. And there's still a history of mistrust among some of the lower socioeconomic and less educated in our community. And so by offering them the choices between the cheaper or the more expensive procedure, their thoughts are if it costs more, then maybe it's better. And this is a long history, and the mistrust and what to do and how to proceed, it becomes very difficult. And so my question to you is how are you going to address this huge subpopulation or group in our community which still has a big mistrust? Patient quality then becomes dependent on whether or not you're giving them what they think is the best surgery because it costs more, because that's still where their understanding of medical care is.
I can tell you we don't try to change our protocol depending on what a patient can pay, and we let the patient know that. So regardless of what their socioeconomic status is, or whether they're private pay or whether they're Medicare or they're no pay, we don't change the protocol, nor do we change the prosthesis that we use. And I make sure they understand that. The other thing we do is if somebody doesn't have insurance, we go to the administrator, and I've got to give St. Mark's credit here because they inevitably will come out, and I've seen them write off huge bills for people that can't afford to do that. So I think that's a way to build trust in the patient, and it's a way for us to continue to give good care. I don't think you can give one person one thing and the other person the other thing. I think they all ought to be cost efficient, but everybody ought to be able to have the same procedure. Well, the same procedure within certain guidelines. I think surgeons are very acutely aware now of cost, and we've worked hard at our hospital to do that in association with the hospital. As earlier mentioned, how are patients going to find out quality? They're already doing it. It's called the internet. And patients don't understand the equation for value. They could care less, quite honestly. What they understand is going on the internet and going to where other patients have been and seeing if you have 4 or 5 stars or 4.5 stars, and they want efficiency, they want quality, and they want somebody they can talk to. And they get that from talking to other patients and other people who have been in a certain surgeon's office. And so that's how I think the message gets out there. When it comes to cost, it's still a nebulous deal because hospitals are free to put out these outrageous bills. I don't know about the hotline at IHC, but I suspect what they get when they call that hotline is, this is your benefit, this is what your out-of-pocket's going to be. They don't see what the actual bill is, which is artificially inflated. I know it is for St. Mark's, and I suspect it is for all the other hospitals. It's just inaccurate data that gives the wrong perception. And I got off topic there, I'm sorry. And I didn't mean to be the grouchy one here today, by the way. I was just, it's my Italian heritage. I just got a little passionate about it all.
Keeps us all grounded. So, Dr. Lewis, I think that's a really great question, and it reminds me of a study that Mayor Bloomberg in New York City conducted a few years back when he implemented caloric labeling. So, Mayor Bloomberg is a real public health advocate, and so he thought, well, if we put the calories at McDonald's, at Starbucks, or whatever, that people would make healthier choices. And as a result of that, there was a study done that looked at behavior change after they did caloric labeling, and they found socioeconomic differences. So people who were from lower socioeconomic backgrounds chose the highest possible calories they could get for their dollar because that was value to them, right? They thought, oh, more bang for the buck. Let me get the double bacon cheeseburger with extra fries and supersize the Coke. So it was interesting because it opened up our eyes in healthcare. We thought, oh, well, obviously, this is what you would do. And it made us all realize that our messaging really does depend on who the audience is, their degree of trust, their background, the way they're thinking about their own healthcare. And for me, as somebody who's also the dean of the medical school, I think it's really imperative for us to make sure that the providers that we're training really reflect the communities that we're trying to serve. Because I think that the people who are best able to understand those needs and those perspectives are people who probably have some connection or a better sense of where those people are coming from. Because we can talk at people all we want, but as you alluded to, people might not take away the same message that we might in terms of cost. Oh, look, lower cost. They might suspect that we're trying to give them a lemon instead of a better deal. So I think that's really important. And I wanted to follow up also on the communications and the education side of things. I have to hand it to the Mayo Clinic. I think the Mayo Clinic has really gone way ahead of most of us in terms of really trying to develop online education tools for patients. And while I think some of the older data suggests that maybe there wasn't such a significant impact for that, the trends are that people are going online more and more all the time now to get information about healthcare. And I think we're just going to see that continue to grow. It's never going to replace what references and human contact in our social relationships and so on provides, but it's going to become more and more important. And the degree to which we can provide good reference material for people to understand what their choices are, whether it's tonsillectomy or appendectomy or prostate surgery, I think it's going to be very helpful for us because people won't really be able to gauge what an outcome, what to expect in terms of their outcomes and whether they've gotten a good outcome if they're not educated and informed, and we need to do a lot more about that.
Could I just add one comment that might be pertinent to Dr. Lewis's question? Recognizing this discrepancy between how we communicate with certain populations, a study that we did recently was really informative. So at Intermountain, as Dr. Mariana says he does in his practice, we really strive to have one standard of care for everybody. Everybody's a VIP. And for our employed physician group, physicians are paid the same way, whether their patient has Intermountain healthcare insurance, other commercial insurance, Medicare, Medicaid, or no insurance at all. But beyond that, the question I think you're asking is how does that get translated in the patient's mind? And we were very sensitive and concerned about that. But one study that was really interesting, we were tracking patients with chronic asthma through our clinical program in primary care for a long time and have had improvements in helping patients take controllers and everything. So one of the things, this is a non-surgical example, but I think it might be pertinent to your question. One of the things that our team did a couple of years ago was introduce an online application, which is also available on your smartphone, of tracking your asthma symptoms. So once a week, you complete a 5-point questionnaire, things like how often did your asthma interrupt your sleep? How often did you have coughing or wheezing that interrupted what you were able to do? How often were you not able to do your daily work activities? Things like that. And tracking that, and found that, and the program is such that if your symptom score starts to creep up, then it puts you in contact with your physician who's managing your asthma so they can adjust medications. And what we found, probably not surprising, is that people who use that had a significant decrease in the number of times they came into the emergency room for their asthma or were admitted to the hospitals. What we didn't anticipate was the most dramatic improvements were in our Medicaid population, where the decrease was much more dramatic than in the general population, and in our Hispanic population, which in our community tends to be more economically disadvantaged. And you might not think that, that other people are going to be connected, but those were the people who really benefited from it. And what I'm saying is I think there's a real hunger among everybody to understand and to be involved in their care and to make wise choices.
David?
Just to add to the discussion on what can be done, our leadership has sort of declared there is no quality without access, and whether it's direct access or it's access denied due to cultural differences, I think there's a huge problem still in this country. And one of the things we're going to do is we're going to create a conference with NIH to try and open up, at least discuss what is the waterfront, what's the scope of the problem, what is best practice, and that's going to occur in the spring, so watch for that. The second thing is that the Operation Give Back program, which is a college program that really has focused on international health, we're going to, with our redevelopment of that program, we're going to focus it as well on domestic disparity problems where access is a problem. And there's some incredible experiments going on. For instance, in San Francisco, the Kaiser system offers their operating rooms to volunteer surgeons on Saturday and Sunday, so that people that don't have access can actually get an operation done electively on Saturday and Sunday for essentially free. So I don't know the answer, but there are a number of programs like that around the city. And so this is going to become a much more organized effort to try and understand best practice, what some of the disparity issues are. Dale Hyder has just moved from Hopkins up to Boston to head a program at the Brigham and Women's Hospital to focus on this, and he's going to be involved. So, if you're interested in that topic, there's going to be some stuff that the college is getting very deeply involved in.
Sitting here thinking that with being on call, we've done plenty of operations for free on Saturdays and Sundays, so I don't know that that's solved the healthcare problem, but anyway, I'm Dr. Childs. I've been in private practice in urology for over 20 years, and I feel a little like I'm back in a junior high geometry class. I recall the thrill of learning this thing is obvious, this next fact is obvious, this next fact is obvious, and we put this and this and this together, you come up with a conclusion. And so I don't disagree with anything any of you said. I've really admired all of your comments, have been very good. And and I come from a background, I should just preface by saying, I recall watching Dr. Sorensen be a resident in urology at LDS Hospital. Back in the day when I was what was called a summer wonder, I was helping be a computer tech, developing in the early days with Homer Warner and Reed Gardner and Alan Pryor some of those computer programs. It was a fantastic job when I was a little kid, basically, doing things that you can't even do anymore. I mean, I had incredible OJT experiences before I got into medical school. So I admire the data and the constructs that now Intermountain Healthcare has in that. And my geometry comments are such that I see these facts. Number one, we all want quality measures for our patients. Number two, we all know that cost issues are critical. And I think Dr. Ott's comments about being able to see on a board how much a piece of, health costs, how much a piece of, a me-fix costs versus just a piece of gauze and a piece of tape and whatnot. It can, create the same kind of bandage, and yet the one is extremely more costly than another for a particular procedure. Behaviors do change when people have data. So data is bottom line, is going to win at the end of the day. And some of us that are in private practice situations also sometimes work in some of the bigger facilities, the Intermountains, universities. Since we're responsive to patients, we want to be advocates for patients. If data is going to win, how will the smaller physician groups that are not within an Intermountain or a university or whatnot, and even putting those kind of data groups together, how will they survive in the long term? Because data is going to drive the train. And we can have 5 stars show up on our health grades on the website, and patients can give me a good grade, and I'm fortunate to have good grades, but do I really have the ability to show what my cost is and all that in the big picture? It requires a big machinery of data. And so if we all really want to help medicine progress and be an advocate for patients, what say ye that are the Intermountains, universities in fairly big data pool, have ability in those big data generating facilities, and then the rest of us that are sort of outsiders. I mean, I tipped my toes into Intermountain. I did a big operation with Ray Price, a few months ago, and so I'm involved in lots of things. But at the end of the day, the small private practice people are going to get squished, it seems like, if data wins. So how do we move this all forward, or do we continue to war with each other? Because we're trying to be advocates for our patients. We talk the talk. We want to have good quality. We want to have good care for them. But if just the big machinery data is going to be able to pull that off, they're going to squish everybody else. And is that the goal? That's what it feels like.
I need to make that a little bit more precise. You're spot on, but to make it a little more precise, the prediction is, and almost certainly this is true, we're going to see with increasing frequency providers bearing the financial consequences of healthcare consumption decisions. The Pioneer ACO legislation actually had built within it 6 levels of increasing provider at risk. It goes from fee-for-service medicine and ends up with full population level capitation at the top, and it was a plan to try to move practice groups up that chain. The way that plays out is more and more the people who are looking at your data are not the patients, not even the insurers, it's the referring physicians. If you're a specialist and they're referring to you, the physicians who send you patients are going to be looking at that intently, because that money's coming straight out of their pocket. It's interesting, one of my students is back in Massachusetts, and he describes exactly this as part of the Beth Israel Deaconess Extended Care Delivery System. Exactly this right now today in Massachusetts, of all places, going on. Now, relative to the data and how you get access to the data, you're right, you do have to have access to those data. It's the old idea, come back to life again, of the group practice without walls. Doesn't mean you have to be employed, by the way. In every instance, there's a consolidator. If you look around the country, in every instance, there's a data consolidator at a local level. David would have to discuss this. I'm not sure the College of Surgeons can do it rapidly enough or with enough cost data in it. For example, over in Grand Junction, Colorado, it's an IPA model physician group who acted as a consolidator and transformed that community, frankly. In Indianapolis, it's the Regan Street Institute, a university-based IT group who does it. In many instances, it's a big care delivery system like the University of Utah or like St. Mark's or like an Intermountain in this community, but there's always that data consolidator. And so as a physician in private practice, you're going to need to think about who's my partnership practice group, even though we're not financially combined. That'll probably come. You will become economically combined, even though you're not employed, but particularly in terms of clinical outcomes and best care. Again, think of the target audience being perhaps mostly referring physicians, even as opposed to the patients. They'll see the data too, and that's useful. We ought to do that. It's the right thing to do. But it's very clear that that's the way the world is headed.
So I think that's a really terrific question, really hard question. And you know how sometimes when you work on a problem, it gets really complicated, and then when you get to the end of it, it's actually pretty simple? One of the things that we've learned at the University of Utah through this journey to develop this value-driven outcomes tool, which gives you the outcomes against the cost and is really big data, kind of big data. Just the original program was 150 million lines of code, right? What we learned at the end of it was actually, you know, if we looked at one of the initial projects was total joint replacements. So we gave all the orthopods their outcomes against costs for total joint replacements. And what we saw was some variability, not a huge amount of variability for, say, total hips, but there was practice variability. And so we put them in a room together, and they all looked at the data, and what they figured out was that they came up with their own outcomes index that included skip measures and stuff that we have to worry about, but then also they included things like early mobility. So for them, they said, got to get out of bed that first day. That's like the most important thing. Even if it's not on some core measure thing or anything like that, we want that to be in there. And when they looked at the variability across patients, what they discovered was there were kind of two groups of patients in terms of outcomes and costs. The group that got the physical therapy the same day, they tended to come out of the OR earlier in the day. And the ones that came out of the OR later in the afternoon, physical therapy had already gone home because their shift ended around 4 o'clock. So as a result of having the data, what they did, kind of reduced to something really simple. We actually just expanded our physical therapy coverage so that everyone got out of bed the same day. And as a result of that little project, that little experiment, their outcomes number, and they were just tracking their outcomes, kept going up. And our costs, was around 25-30% savings just in the first year. So we've seen this pattern over and over again where we don't even need to look at the cost. I hate to say that because I know this is all about cost. We can blur out those numbers actually and just give people a relative sense. In fact, despite all of our really hard work to know the true costs, just knowing charges as a surrogate would probably be sufficient enough because there's enough variation. And our philosophy, we're a state institution, we're a public university, and everything we do, we consider this to be to help other folks. So since we've been talking about the value-driven outcomes and since it's been getting some press, there was a piece in USA Today this summer, and we got a lot of calls from all over the country saying, how did you do this? And we've been very happy to share with folks the simplified version. You could do 150 million lines of code if you want to, but we probably have some lessons that we've learned after coming out of that, that small practices could take on. I do think you need the data, but whether you need all the same degree and intensity and detail of data, probably not, to drive the change that you need to drive and to be able to report your improvements and your high quality the way you want to.
Dr. Hoyt has eagerly been waiting to say something, and I suspect it relates to collaboratives, but I may be off base.
No, it's to the question about the individual surgeon or the small group. We've developed a new registry called the Surgeon-Specific Registry. It's targeted at all surgeons, all procedures potentially, but we've done it in conjunction with CMS and we've done it in conjunction with the boards. We just presented this to all the boards, all the ABMS participant boards in the last 48 hours, and there's a broad interest in this kind of approach. And what it allows you to do is for an individual surgeon is to collect data on key cases that characterize your practice. That allows you to then participate in practice-based learning. It allows you to tailor your learning to things that are relevant to what your practice is. That allows you to participate in Part 4 of maintenance certification. It can be used for your hospital, for Joint Commission OPPE. It can be given for PQRS. And so we're developing a whole tool set. It's got a risk calculator for an individual patient that's correlated to a national database. You can put guidelines in that are either college specific or your local specific, so that when you're at the point of care with a patient, signing them up for an operation, you can have an informed consent decision-making process that reminds them of certain things and also gives them a risk calculation. So we're trying to create a comprehensive tool just to that point. And then the opportunity to give back benchmark reporting will be part of that. So right now we have 4,000 surgeons participating in that, and that's going to become a major focus for the college in addition to databases like NISQIP.
Mark?
I would echo that. There's a lot of tools that sit on the ACS website that are really useful to an individual surgeon, the risk calculator, things like that. It's important to understand, and this gets to Lane's question, it's important to understand how hard it is to get your data to the point where it's actually usable. There's the administrative data that every system has. There's not a hospital that you operate in that doesn't have cost and some series of 10 outcome measures kind of data, and they all have that. But unfortunately, that data is very difficult to interpret because individual surgeons have low volumes, and so statistical variation is just all over the board. And so it's for an individual surgeon, it's okay for the hospital level, but an individual surgeon level, unless you're incredibly high volume in certain procedures, it's just uninterpretable. So we spend a lot of time, and I do this thousands of times by now, but when we're trying to get an answer to a data question, we always go through and answer the question manually because we know how to go through it and get it that way. And we figure out from the manual method how to convert that into an electronic method of culling the databases that we had to go to get that. And then we figure out from that standpoint, how do we write the program? And after lots of work, where we've got a computer program doing that at midnight every night to give us fresh data on whatever time period we want to check on, then we go out and we give it to the surgeons. And I can tell you the first 2, 3, 4 times that we show the surgeons the data, immediately the surgeons spot the defects in the data. Okay, they say, well, I do a lot more of that case, and this is, and they're right. They're always right. Our first passes at building the computer programs that it takes to get the data that they want is always wrong. And we go back and we rewrite the program with the input that they've given us. And we show it to them again. And after about several iterations of that, then we get to a point where everybody starts saying, yes, those numbers fit with what I feel is right in my gut. But the point of it is, and this gets to your question, Lane, is that that can only be done if we have a system that's willing to, whether it's your group practice or whatever, that's willing to put in that computer programming time and has somebody who can do it. But it also requires surgeons who are willing to go and sit down and review the data and help the programmers and the data people get it better. And that's kind of the rub, is that we have not been as good as we want on that. I mean, if I want surgeons to show up at a meeting and I tell them it's about helping us write a pathway or data or something like that, I'll get 2 or 3 nerdy type show-ups. But if I really want them to show up, I lie and I tell them it's about pay and about call. And then I get about 70% of them that will show up, and we'll talk a little bit about pay and call, and we'll talk about these other issues. So, we have to be participatory in it, and the people who don't show up, I can't fix their problems if they're not going to help me write the programs and give me the data that they can use every day. You cannot extract this manually. We don't have enough residents, we don't have enough slaves. We need the computers to do this for us to help us get better.
To your question / concern, I think I want to be fairly blunt. We'd love to sit here and say, you're going to be fine, don't worry about it. But being a fiercely independent private practitioner is an increasingly dangerous place to be. Because much of what we're learning about delivering the best value care relies on integrated, coordinated systems. So unless we can come up with new models for integrating private, fiercely independent private practices into larger systems of care, I think we're in real trouble.
But there's also, the smaller hospital. I represent a critical access hospital in southern Utah, and I look at what they have to deal with in a smaller setting, and then you have smaller clinics too. I think with the bigger systems and institutions, if you have, you have a quality metrics oversight committee that is looking at what different inputs, what measures and metrics are going to be included, and how the data is going to be looked at, that there needs to be an overall attitude or strategy with that committee. When we're going to add something, we're going to decommission something. And you add a metric, you decommission a metric. Now, the CMS does that to some degree. They decommissioned 16 in 2014, but they added a lot more than that. But the point being here is that to have a real level playing field and also have an efficient system, and also to do this resource, when we talk about cutting waste by 50%, there could be a lot of waste in not just the measures, but also the data compilation and the effort we go to require a lot of resources to maintain some data collection that is maybe no longer necessary, especially as evidence-based medicine marches forward. Usually as it marches forward, it leaves something behind. Is that being cut off when it needs to be, so that you're not, as a smaller practitioner in a smaller setting, put in a situation where you're having to deal with a lot of extra stuff that everybody, all things considered, would not be using anymore, but for the fact that it's there.
Yes. Dr. Evans.
Good morning. I'm Kendricks Evans, one of the surgery residents at the University of Utah. And I have a kind of a two-parter question. We know that healthcare delivery is the new topic, and as far as patients' information and then also their satisfaction levels and how that's going to affect us in the future. But I'm wondering, what are the thoughts on not just the informed patient, but the realistically informed patient? And it leads me to think of things in the way of, let's say, pain management. We look at a lot of, are the patients satisfied, are they not? And then what would prevent us from becoming very Pavlovian in our responses to, we're not getting the 5-star reference versus you may miss those things. And I think that we see a lot of it with our patients dealing with pain, for instance. If, yes, you have gallbladder pain, that should be different because it's gone, but we just literally stab you to take care of that. And so my question would be, what are we keeping into position and in place to not only deal with a patient who is satisfied and where we do our press gaining and we do well, but also at the same time making sure that we're informing the patients, you're having a procedure, these are the other issues that go along with it outside of just the global, I'm happy and I'm 100% pain-free.
Sarah.
I think the whole pain issue is really fascinating. And at our hospital, we think that this is wishful thinking, that our numbers went down in satisfaction when they made pain a vital sign. Because before then, people said, you're having surgery, it's going to hurt. I myself had a total knee done, and I'm telling you, every day that guy told me, this is going to hurt, okay? It's going to hurt a lot. And so I was not at all prepared for how bad it really did hurt. But if, when I see somebody for appendicitis in the emergency room, I say, you're going to feel better when you wake up from this. It's going to hurt. I mean, your incisions are going to hurt, but on the whole, you're going to feel better. But when we deal with somebody who's having a purely elective operation, like an inguinal hernia or a total knee replacement, who is pain-free from the get-go, that you can't adequately prepare them, I don't think, or at least we don't usually adequately prepare them for how bad pain is and that it's a part of the process. We try and do as much as we can to alleviate that, but it's not a pain-free thing. And when a patient comes in and they're talking on or when I come into a room and they're yakking on their phone and how's your pain? Oh, it's a 10. No, it's not. I'm sorry, it's not. I mean, getting your leg blown off in the Civil War and having somebody cut your leg off without anesthesia is 10. Talking on your cell phone, I'm going to give you a 3 at the most. So and it goes back to what you said about knowing our patient population. Some patients have a different expectation of how this is all going to go for them, and we need to educate them up front on that. And I think our scores will overall improve because of that.
Just to give you a sense, so when I first moved to New York, I'm from Oklahoma originally, but I lived in New York, and when I first moved to New York, I was a fellow, and I had to put IVs into patients after hours after the nurses went home. And my introduction to Manhattan was this woman who came in with her arm wrapped in saran wrap because she had coated herself with topical lidocaine and saran wrap because she was so nervous about the pain of the IV. Just to kind of reference the pain conversation.
How many tattoos did she have, though?
We have time for one more question.
You know,
So,
I think
Sorry.
Dr. Harmon's been trying to ask a question for quite a while on this side over here.
Quick question then. I'm Daniel Gilsdorf. I'm one of the surgery residents here. As we move towards standardization of materials, methods of doing things, finding a pathway to perform a laparoscopic cholecystectomy, for example, when we do that, the residents are exposed to one way of doing the procedure. Is there concern, and should there be concern, about the detriment to resident education of streamlining and finding a one-way pathway to do things?
I think it comes back to the science of medicine. I hope that in that same program you're using that standardized environment to systematically learn. I got my start at the Dana-Farber Cancer Institute doing trials of cancer therapies, and it's the funniest thing in a trial, you use protocols in the arms of your trial. The reason is if you don't do it the same way, you can't tell how outcomes link back to what you did. You can't get a causal link between treatment and outcome. So one of the key ideas behind learning in a learning healthcare system is standard work. You can use that then to systematically improve. The difference is you'll have to function as part of a group. It'll be you and your colleagues saying, well, let's test this, let's test that, let's see if this works better. But it gives you a framework in which you can systematically improve, and frankly, over time, it's the history of success in medicine. That has what has led us to where we are now, and that's what will lead us to something better in the future. I'm really trying to say, don't confuse the idea of personal autonomy with professional autonomy. We're not here to give you a smorgasbord of ways it could work. We're here to show you what currently is the best practice as we now understand it, and methods by which you can be better tomorrow.
And I would say that you're fortunate in that you're in a residency that's got a university hospital, a VA hospital, a primary children's hospital, and a community hospital system. And there are opportunities for all of you, I know in your residency, to go with Ray Price or one of the other surgeons somewhere to some third world country and see a completely different way of doing things. So I don't think that you're in any danger of not being exposed to multiple different things when you're in a residency that has multiple hospitals in its system. And I think that's how residents should probably be looking at their residencies, to be honest.
You know, somebody alluded to a book by Richard Bomer earlier called Designing Care, and I think in there he says even when you do these care pathways, maybe at least about a third of the patients probably would not fit the pathway, and it's probably even higher in teaching hospitals or in more tertiary care centers. So I think partly what you're learning during residency is when to stick to the pathway and when you have to deviate off and how to do that. I think that's actually a critical part of your training.
Go ahead.
Just want to ask Dr. James real quick on a follow-up about what he was mentioning. You were saying that ultimately the referring physicians will have that data and they'll be the kind of drivers. How do you foresee, just what would you guess the future will be like? How will they get that data? Will they go to an online thing and pull up my name and get it? And where will that data come from? The hospitals I'm associated with, the American College of Surgeons, the government? How do you see that playing out in the future? And then finally, just a comment, if anyone could comment on it, the concept of warranties associated with surgery, and how you see that playing out in the future or with the health, the organization you're with. I think that's going to become part of some bundled system or something, but I think the warranty thing makes sense. Just wondering how you see that playing out, or if at all.
The way Massachusetts started to offer population-level capitation primarily to primary care groups. And that meant that the primary care physician groups were examining the specialists that they used, including surgeons. So Ash Levitt, my student, who was medical director at a community hospital, describes the primary care group coming in and saying, this is what you are charging us for a total hip. This is what we're paying you for a total hip. This hospital is doing it for 20% cheaper. Do you still want to work with us? Now, they were driving it purely off cost data, frankly, and Ash was able to respond to that quite nicely. And what he did was he actually was doing a pretty good job of stealing cases from Brigham and Women's and Mass General under that system. As it played out in the long haul, his volumes were coming up quite nicely in that regard. They were responding not to an insurance company, they were responding to a bunch of physicians. Now, in Intermountain at the moment, just to carry that one step further, we're launching something called shared accountability. It's a similar sort of a thing where physicians bear not all of the risk, the system handles most of it, but some of the risk. It's a transparent data system where it shows your clinical results, your satisfaction results, and your cost results, and it's displayed by name. The people who seem to be taking the largest interest in it are those who refer. I think you'll see more of those systems. I think that your practice will become transparent to your peers at a referral level. The data systems behind them will come through some sort of a consolidated function. If I were in Grand Rapids, it would be through that IPA. If I were in Northern California, it would be Health Physicians who do this. It's about a 2,000 physician group, an IPA model, again. If I were in Indianapolis, Regan Street does this sort of stuff. If I were in Massachusetts with ASH, it would be a physician group working with Blue Cross Blue Shield. If I were at the university, it'll be the university doing it. If I were at Intermountain, it'll be Intermountain helping to facilitate the creation of those data. Now, at least for Intermountain, we try to do it for community-based affiliated physicians as well, not just for employed physicians. We do it across the board. That's what I mean with the group practice without walls. You don't have to be employed. It still works. But you will have to be part of a professional group of some sort. So, what was your second point?
Warranties.
Warranties.
Sarah, do you
warranties
have a
really
warranty
started
on
with Geisinger with what they called proven care. It was done on a very small scale, but they had two conditions where they basically said for this surgical procedure, we'll give you a flat rate for the entire procedure, professional fees, so a full bundle, professional fees of every sort, including the surgeon, the anesthesiologist, and the radiology that was done, and a follow-up tail. The follow-up tail varies based upon the specific procedure. So you're looking for specific complications associated with the procedure, and as part of the bundled price, you handle and manage through the life of the procedure to its eventual conclusion. So I think for total hips, they're tracking about 8 months, and then tracking any related complications, and they covered that care under the same price. So that's how warranty care works. Is a bundled package including the entirety of the care for a well-defined, usually a procedure of some sort, and all associated complications. So if the patient had an unassociated complication, that's not covered under the warranty, but for associated complications, they are through some defined period of time, and it varies depending upon the procedure or the condition.
So Brenda referred earlier to these different payment models, and the warranty really functions at the bottom of that hierarchy of payment models. And once at the top end, where you're talking about capitated care and ACOs, the whole shebang is a warranty. I mean, it's all the warranty becomes irrelevant.
Charles, did you have something to add, or did Dr. Finlayson make your point?
Exactly.
Okay, perfect.
We need to hear from the attorney.
Tim?
Oh, yeah, warrants, it's like a lawyer's paradise. But just after listening, though, to the issues regarding the future and the challenges, I'm really glad that I'm a part of a sort of an archaic profession without the level of oversight, insight, and transparency that you're facing. And in some ways, I mean it in a comical way. In other ways, it's very serious and a real challenge. And for the young people in particular going forward as surgeons, I think it's going to be even more challenging, because in the end, value is, you can't over-intellectualize all of these empirical, evidence-based things. It's like in baseball. Because baseball is so boring, everybody talks about statistics, and everybody talks about everything going on, even when they're at bat. But the only thing that really counts is the hit. And so you treat the patient and not the disease, but sometimes the more you do that, the more you can get yourself in trouble, the way the direction I think some of this is going. Because in the end, you're not working for a patient. You're the patient's doctor. It's like I tell clients when they hire me, I'm not working for you, I'm your lawyer. Because it's a relationship that's totally different that we have, that you have with people, that the law allows you to have, that's more unique than most other relationships that exist. And it's like a minister and stuff. You have a relationship with your patient. And so I'm not sure I see the empirical, systematic issues that we've talked about today, facilitating that close relationship that you need and that the patient needs to really be successful for value.
Sarah.
I have one more comment on the warranty issue, and to tie it back to geometry, I had a one-armed geometry teacher, so he would say, picture a right triangle. So I've always thought, I'm missing something in any conversation, and in a warranty and in ACOs especially, what's missing is the patient and the patient's responsibility in their care, whether they get out of bed and don't just go home and hit the couch and don't take their aspirin and don't keep their wound clean and don't do their deep breathing and everything. The burden falls on all of us and on all of our systems, but the patient is somehow left out of that equation. And I think we have to keep that in mind and try and get them involved, but that's an uphill battle.
That will be our closing comment for today. I want to thank everyone again for taking the time to be here, and I particularly want to thank our panelists. I do want to note Dr. Mariani did not leave because he was grouchy or angry or anything else. He told us first thing this morning that he had a flight that he had to go catch, so please don't think that anyone offended him. Thank you very much for your time. I hope this is a dialogue that we'll be able to continue, particularly with an eye towards collaboratives, because I know that that's a big effort that the college is continuing to pursue. And for those of you heading to the chapter meeting this afternoon, I'll see you in a little bit.